This conference will now be recorded.
Anybody volunteer for first station? Hello, can you hear me? Am I audible?
Yes, yes.
Yes. So nobody wants to do the station? Okay.
Hello. Good evening, Dr. Mrudula.
Yes.
Hello.
Yeah, Dr. Bushra. Yeah.
I can volunteer.
Okay,
Yes,
sure. Okay. So 1 minute. So this is your station. I will start your 2 minutes. Whenever you want to scroll down, please tell me. Okay?
Just 1 minute, ma'am. Hello.
Yes. Hello, Bushra.
Okay. Yes, ma'am.
Yeah.
Yes, ma'am. Yes.
Should I scroll down? Should I scroll to the
1
next
minute,
slide?
ma'am.
Okay.
1
You tell
minute,
me
ma'am.
whenever. Yeah. I'm starting your 2 minutes. You tell me whenever you want to go to next slide. Okay.
Okay. Okay, ma'am. Next slide.
Okay.
Okay, ma'am.
This is the first CTG, and there will be one more. Okay. There are total two traces are there, and based on that, you have to do this teaching station.
Okay. Okay, ma'am. Just, ma'am, can I take 1 minute?
Sure. You tell me whenever you are ready. Okay.
Okay, ma'am.
I have started your 2 minutes. I will tell you whenever your 2 minutes are over. So shall I move on to the next trace? You want to see the next trace also? Yes, Bushra. Hello, Bushra.
Hello. Yes, ma'am. Can I start?
No, there is one more stage. That's why I wanted to tell you. There is one more CTG. So you want to see that?
Okay, ma'am. Okay, ma'am.
Yeah. So this is the another one. You can start. Actually, your 2 minutes are over. You can start. There is no problem.
Okay, ma'am. Okay. So, 1 minute, ma'am. Just I want to confirm this is a teaching station.
Yes.
Right?
Yeah.
Okay.
See,
so
this is the station. Okay. This is your station. These are the two CTG presses. Okay.
Okay. Okay, ma'am. Okay. So, hello, I'm Bushra, ST5, and you are?
Hello, Bushra. I'm Anna, and I'm ST1.
Oh, nice to meet you. How would you like me to address you?
Yeah, Anna is fine.
Okay, Anna. So I can say that you are you have recently joined the department. So how's everything going in the department?
Yeah, everything is going well here. Actually, I'm enjoying working here. Everyone is so friendly and they are helping me a lot. So I'm enjoying actually here working.
That's really too nice. That's really too nice. So a warm welcome from my side as you have recently joined. Anna, I want to tell you that if you have any questions, any problem, you can tell us and we are happy to help you anytime. So Anna, I can understand that today you are here because you want to discuss about the CTG. Am I correct?
Yes.
Okay, so Anna, can I know? Have you learned anything about CTG before?
Yes, actually, I know regarding the CTG. I know the basics of CTG also. Like, what do you mean by heart rate, acceleration, and all those things? But the point is, I usually get confused while interpreting the CTG. I don't know exactly how they classify this reassuring, non-reassuring, or abnormal or suspicious CTG. That I really don't know how to do it. That's why.
Okay, I really appreciate that you already know the basics of the CTG. That's very good. And Anna, today, before that, I would also want to know, this is only a purpose, means why you want to learn CTG, that there is confusion in interpretation. Am I correct?
Yes. Actually, yes. I don't get the idea when they do the management depending upon the CTG, when they so pathological. What is the difference between suspicious and pathological? I really fail to understand sometimes.
Okay, Anna. Okay, Anna, I do understand that it is difficult, but with time, I can reassure you that with time, you will be able to learn all this, and you will have enough experience in interpretation also. So, Anna, today I will be today I will be discussing with you the basics of the CTG, and then how we interpret CTG according to the NICE guidelines, and then how we manage. Okay? Okay, Anna? Hello? Hello? Ma'am, can you hear me? Hello? Can you hear me, ma'am? Shall I continue? I cannot hear you. I cannot hear Dr. Mrudula. Shall I continue?
Yeah, no one can hear
Okay,
her
ma'am.
actually.
Okay.
Maybe some connection problem.
Okay. Okay, you'll see the CTG by this time. Ma'am, once you can hear me, please tell me. Shall I continue? Okay. Okay, I'm continuing. So, but I want to see the full CTG. So, first, according to the NICE guideline, we have to see, once we are having the CTG. First, we have to describe the CTG according what we are following is we call Dr. C. Bravado. There is a mnemonic that makes us CTG interpretation easy actually. So Doctor is for determining the risk. Whenever better wait for her. Okay.
Yeah, because she will be giving you feedback, right? So better to wait for her.
Yeah, you're right. Okay.
Yes. Hello.
Yes, ma'am.
Hello.
Yes.
Yeah.
Yes, ma'am.
Yeah. So
Okay,
I
ma'am.
think you have to start with this thing. Start with your agenda and this thing. I have stopped your time. So there are 8 minutes now. You have to explain it. Okay. So start with the agenda and this thing. Okay.
Start with agenda. Okay.
Yeah,
So,
because first the introduction part is over. You will start with your agenda. Yeah.
Okay, so today I will be telling you, I will be discussing with you what are the basics of CTG, how we describe CTG, how we interpret, and what are the management according to the NICE guideline. So anytime if you feel, if you don't understand anything, you can ask me and you can interrupt me, and you can you can ask me question anytime you feel. Okay. So.
Sure.
Can I, sorry, can I know your name, please, again?
Anna.
Anna. Okay, Anna. So, Anna, we are describing the CTG according to Dr. C. Bravado. This is one mnemonic we are following that makes us description of the CTG easy and to remember. Okay. So for
Yeah.
CTG, DR is for determining risk. Means we should not interpret the CTG alone. We always interpret the CTG according to the clinical. First, we assess the clinical risk. Okay, what is the
Yes,
scenario
yes.
of the patient? How much risky is the patient? Okay, it is a low risk patient or it is a high risk. For example, if patient is having a history of diabetes, hypertension, or having bleeding, so these are high risk condition. So we have to take history first to assess whether my patient is a high risk or low risk. Okay, this is first part. After that, every CTG strip, after assessing the risk factor, whether patient belongs to a high risk or a low risk, then we see what are the 4 basic components in the CTG. So as you have already told me that there is 4 things we need to see. That is the heart rate, second is variability, and third is do we have any accelerations or deceleration. These 4 variables are there that we need to see in every CTG. Am I clear, Anna? Hello? Hello? Am I clear? Hello? I
Can't
cannot
hear
hear you.
her. Yeah, can't hear her.
Hello,
Yes,
Bushra?
ma'am. Yes, ma'am, I can hear now. Okay, I will go on. So CTG, the 3 things, first is heart rate. Let's talk about heart rate. What is a normal heart rate is? From 110 to 160 beats per minute is the normal heart rate. So all these 4 variables are further categorized into reassuring, non-reassuring, and abnormal. Am I clear so far? Hello? So, hello.
Hello.
So the
Yes, I can hear you. Only thing in between the voice is breaking. Yeah, I can hear you.
yeah, ma'am,
Yeah,
I could.
go on.
Okay, okay. Your voice is not coming actually, so I'm
Yeah.
little bit confused. Okay, so heart rate
Right
is
now, it's
100.
okay? My voice is okay? Right
Yes,
now, you are
ma'am.
here.
It's
Yeah,
yeah,
okay. Go
yeah,
on.
ma'am. I can hear you.
Yeah.
So first we'll talk about the heart rate. The normal heart rate is 110 to 160 beats per minute. If we see the heart rate is between this, then we can say this heart rate is reassuring. But if the heart rate is less than 100, less than 110 or more than 180, then it is a non-reassuring feature. Okay. And if
Okay.
the heart rate is less than 100, then it is a abnormal feature. Am I clear? That
Okay.
all
Yes.
3 variables we categorize into 3 parts: reassuring, non-reassuring, and abnormal. Regarding variability,
Yeah.
normal variability is 5 to 25 beats per minute. That is a reassuring feature. If the variability is less than 5 beats for 30 to 50 minutes, this is non-reassuring. And if it is more than if it is more than 50 minutes, less than 5 beats, that it becomes abnormal feature. Okay. And similarly,
Okay.
if
Yeah.
variability is more than 25 for more than 15 minutes, 15 to 25 minutes, then it becomes a non-reassuring feature. About acceleration, if accelerations are there, this is reassuring. But if accelerations are not there, it doesn't mean that it is non-reassuring. Am I clear so far? Hello,
Yes,
Anna?
yes. Got it. Yeah.
Okay.
Yes, yes. Got it.
Okay.
Yeah.
Okay. Okay. And how we say in the CTG that it is accelerations? When we say it is accelerations, actually, in acceleration, from the baseline, if the elevation is 15 seconds and lasting for at least the 15 beats above the baseline and lasting for 15 seconds, then we call it acceleration. And similarly, if the deceleration, if it is 15 beats below the baseline and lasting for at least 15 seconds or more, then we call it a deceleration. So we are
Bushra, some
having
background noise is coming. Hello.
from my side. Okay, just give me, I'm checking. I'll just switch off the AC, maybe because of that. Is it okay, ma'am?
Hello. Yes.
It's better? Okay.
Right now it's okay. Yes.
Okay. And regarding the decelerations, we have 3 types of deceleration. Early deceleration, let me draw for you. Early deceleration and late deceleration and early, late, and variable deceleration. I will be describing it later on. And there are three types. And early decelerations are actually because of the head compression, okay, which is usually seen in the second stage of the labor, and they are not very frequent. And if it is early decelerations are there, they are means reassuring feature, okay.
Okay.
But
Yes.
if it is a variable deceleration are due to cord compression, and variable decelerations are due to cord compression, and they are the most common type of deceleration in the CTG. Okay, so most commonly we are getting the variable deceleration, and there are many features. If this variable decelerations, when we categorize it reassuring, when the variable decelerations are there for less than 90 minutes without any concerning feature, then we call it reassuring feature. But if this variable deceleration are for more than, means there's many categories we will memorize later. And another is a late deceleration. Late decelerations are always pathological, okay. So these are the categories how we describe these variables. And at the last we have to give an impression of the whole CTG, okay, overall impression. So for overall impression, we have to, if there is all the three variables, means heart rate, variability, and accelerations. If all three are, and there is no deceleration, if all three are reassuring, then we can say the overall the CTG is normal CTG. Okay. And if there is one non-reassuring feature but two reassuring feature is there, we categorize that CTG as normal suspicious CTG. Okay, am I clear? And if we have two non-reassuring features or one abnormal feature, we say that this CTG is a pathological CTG. Okay, so I will tell you again that after DR determined risk, then we are having Dr. C. C is for uterine contraction. So you can see from the this graph, this CTG graph, you can see the lower portion. There are some recordings are there that are actually the uterine contraction. Okay. So C stand for contractions. So we can see from these markings, these are 10 minutes actually, and also we should see whether the CTG is at what rate it is running and what is the time date also we can check, and also the number. Okay. So we are sure that the CTG, I cannot see exactly what's the speed of the CTG right now,
Bushra?
but I can. Yes, ma'am.
Bushra?
Yes, ma'am.
There again, there was some problem with my
yeah,
connection.
ma'am. But I continued this time.
Actually, I couldn't hear from decelerations. You started to describe variable decelerations. No, from variable decelerations, I couldn't hear actually.
Okay, ma'am. Then, okay, ma'am. Ma'am, variable deceleration, I can tell, but I know our time will finish if I'll describe all type of variable.
No, I will tell you. There are still 2 minutes are there because I have stopped the time at the same time.
Okay, ma'am. So they are variable deceleration which are most common, and they are most difficult to interpret as well. And they are late deceleration. Late decelerations are actually always pathological. Okay. We will be so after seeing how we have to give the impression of the overall impression of the CTG. So we have to see all these three things. If all the three variable like heart rate, variability, acceleration, and deceleration all are reassuring, then we say the CTG is normal. Okay. If any one of them is non-reassuring, then we say the overall the CTG is suspicious. And if we find two non-reassuring feature or one abnormal feature, then we say the CTG is pathological. Okay. Am I clear so far?
Yes, yes.
So according to the overall CTG impression, we are doing the management. So for the, I want to tell you some more important thing about, let's see this CTG strip, how we are seeing this CTG strip. So first we have to see where the number and name of the usually patient for whom this CTG is, so that this will confirm that this CTG belongs to that patient. This is the identity we have to check. Okay. After that, we'll see at what speed this CTG is running. It's usually written, but right now I cannot see where it is written. usually 1 centimeter per hour, per minute, or 3 centimeter per minute. It's already written at what speed this CTG is running. And also we can see the timing and date is also mentioned there. So we can exactly can know at what time the CTG was taken. Okay. And another thing I want to tell you, there are some, you can see the 60, 80, 100, 120, these upper portion, this is actually the heartbeats. Okay, the means this portion will tell about the baby's heartbeat, and the lower portion, you can see the millimeters of mercury, is actually the uterine contraction. And between these two markings, there's this time distance. If it is running at 1 centimeter per minute, then this is a 10-minute strip. Okay, from one marking to another marking. So for seeing the uterine contraction from one marking to another. Yes, ma'am.
Time is up, but yes, finish your station, no problem, because there were a lot of disturbances. Yes.
Okay, ma'am. So so between these 10 minutes, I can see that there are 4 contraction in the first 10 minutes. 1, 2, 3, 4. So how we are going to comment about the contraction? We will say that we are having 4 contraction in 10 minutes. So Anna, can you tell me in the next 10 minutes how many contractions are there in this CTG?
Yes, it will be 3 contractions were there in the next 10 minutes. Is it correct?
Very good. Yes,
Yeah.
very good. So we will say that 3 to 4 contraction per minute. This is we can say about the contraction. Okay.
Yes.
And other than this, then what is the heart rate? How this one small block, if we see on the x-axis, I'm always confused about this x-axis. The horizontally, if we see this smallest block, is we see this is 30 seconds. Okay, 30 seconds. The small block is 30 seconds. If we go up on the y-axis, then this is 60. We can see between 60 to 80 there are 4 lines. So every one block is actually, if we go vertically, then it is 5 beats. Am I clear?
Yes.
So far?
Yes.
Because here
Yeah.
the upper portion we are recording the heart rate. So let's see about we are going to see what is the heart rate of the patient, baby. Okay, so we will see. Okay, we'll take the 10-minute strip. Okay, we'll see the an average what is the 10 minute, and we'll try to see okay where the most of the readings are falling. So I can see that in the first 10 minutes the average is around 140 to 145. Okay, this so we
Yes.
are always giving a range, no, because it is changing slightly, and the next 10 minute it is 140, approximately 140 to 145. So the heart rate is around 140 to 145 beats per minute. I think this is the second CTG I'm seeing. I'm commenting on the second one.
Yes.
And
Yeah.
and about the variability, how we are saying we need to take at least 1 minute block and then comment the uppermost and the lowermost marking we are taking. You can take any means any randomly, but it should not be accelerations or deceleration. Other than that, so in the where the most readings are falling, I can see the variability is around 5 beats only, or hardly 5 to 10 beats somewhere. But mostly, if I will leave this to 5 to 10 beats, means more than 5 it is okay. So variability looks okay. And regarding the accelerations, I cannot see any accelerations here, because I cannot see any accelerations. 140, 1, 2, 3. In the beginning there is one acceleration, but not exactly. This is not acceleration. 1, 2, 3, 10 beats only going up. So I cannot see any acceleration, but absence of acceleration is not a problem. If the baseline and variability is okay, then it is okay. And regarding the decelerations, because we can see there are deceleration, and now we have to decide how we are saying that it is deceleration, because we can see from the baseline it is going more than 15 beats and lasting for more than 15 seconds. So it is deceleration. Okay, now we have to decide what type of decelerations are. So for that, we have to see the peak of the uterine contraction. If the decelerations are coinciding with the peak of the contraction, then it is most probably early decelerations. Okay, am I correct? Am I clear so far? Hello? Hello, ma'am?
Hello, ma'am.
Hello, ma'am? Hello?
I think again disconnected.
Yes, it seems it's disconnected. Please, can you use your arrow to point to those things so that we can understand?
Are you talking to me?
Okay, I think the Dr.
Hello.
Hello?
Dr. Mrudula is not there.
She's not
Dr.
there.
Mrudula. Yeah, Dr. Mrudula is not there.
You continue explaining, Bushra.
Shall I
Pucha, can
continue
you
then?
explain
Nah.
again?
We are there.
Pucha, can
So
you explain
you
again?
need to give me feedback after Dr. Mrudula also. Okay?
Sure, we'll give
I
it.
will.
No, I think wait
Okay.
for her. She's the one who can give the
Pucha,
feedback.
can you explain again? Please, Pucha, can you explain again?
What you
Before
want to explain me? Tell me if anything is still now unclear. I will explain again. If I can.
the reading, the speed, how could you really look at the
Speed.
speed?
Okay, because speed is not written actually here, but usually it is written on the CTG paper. The speed at which it is running, the speed where it is written
Yeah,
in
Bushra,
between.
go
No,
on.
this black. Yes, ma'am.
Bushra, yes.
Are you?
Yeah,
Yes.
go on.
Yes, ma'am.
Yeah, yes.
Okay, ma'am.
Again, it
Okay.
was lost. Actually, it's raining. Actually, it just started raining. But
Maybe
yeah,
because.
yeah,
Okay, ma'am.
yes.
So, ma'am, I was explaining about this type of deceleration.
Yeah, you have
S-
come up to the, I think, early, yes, you were describing decelerations. Yeah, go on.
so I was early. So for me, it is looking like early, but because the peak of the deceleration is coinciding with the peak of the uterine contraction, but because all the every deceleration are not of the same shape and size, so it can be variable as well. Really, I'm very confused about the variable decelerations. So I can see that there is small one also, and so okay, I'll consider is a early deceleration because the peaks are coinciding with the uterine contraction, and it is only 20 minutes of CTG, 20 minutes of CTG, and looking like early deceleration. So it is a reassuring feature again. And okay, so heart rate is okay, variability is okay, and these are early deceleration. And even if there is no acceleration, the overall impression of the CTG that it is a normal CTG. So we will the management will be to continue the CTG, or if the CTG has been done, there are some indication of the CTG. So if this CTG has been done because there is problem in the fetal heart rate and patient was on intermittent auscultation, then we can switch over again to the intermittent auscultation until and unless patient says that what is this? ये क्या हो गया यार? No internet access. Charge session.
This is for everybody.
Oh, sorry. I thought something is happening from my side. Okay, so I think ma'am again is disconnected, isn't it? Hello? Hello?
Yeah, yes, Bushra. Sorry, yeah.
Okay, ma'am.
Today I have been suffering this
Okay.
connection issue from last 2 days, 2 or 3 days. Okay, yes, go on.
Okay,
So
ma'am.
now, yeah, you are telling this is early decelerations, correct? These are early
Yes, ma'am.
decelerations or variable.
Early.
Okay.
This is early. I'm taking right now, but Variable are always confusing. Okay, I'll keep it as early decelerations. And for then the
Okay.
overall CTG, as I told you, that this is 140 to 145 baseline, variability is 5 to 10. And then decelerations are early. So by taking the all variables, all are reassuring. So I will categorize this overall CTG as a normal CTG. So
Okay.
patient can continue with the same means continue the CTG. But if patient was before on intermittent auscultation and because of some problem in the heart rate, CTG was done, then if patient wants, we can switch over to intermittent auscultation as well. Okay.
Okay.
So
Yeah.
if suppose if the CTG is non-reassuring, then what management, if any one of the features are non-reassuring, then what management we need to do? If CTG comes suspicious because of the non-reassuring feature, then what we have to do, we have to inform the senior obstetrician, that is usually ST5 on duty, and or the senior midwife, and quickly reassess the patient. Means because why the CTG is suspicious, what are the causes? Maybe patient is having hypotension, maybe patient is having dehydration or increased uterine contraction due to syntocinon or other things. So we have to quickly review the patient vitals, pulse, blood pressure, temperature, and maternal and fetal condition. And okay, so if we review the patient and fetus for any problem and correct this, and also ask the patient to change her position, and we can also give IV fluids if needed. So with these, we'll continue the CTG to see whether it is improving or not. Another result of the impression of the CTG can be pathological when we are having two non-reassuring or one abnormal feature. Then because pathological CT is more means there's more chances that the baby may be having difficulty or maybe having hypoxia. So we have to initially means inform the senior obstetrician or senior midwife and quickly assess the patient for any acute events which can lead the CTG, which can have this acute event. What are those acute events which can cause pathological CTG? Usually it can be if patient is in a labor, rupture of membrane, it can be cord prolapse,
Yes, it
be
can
rupture.
be.
Okay, it can be rupture uterus, it can be bleeding, means abruption. Okay, so usually or hyperstimulation is there. So these are the usually acute events. The aim of the examination of the patient is to rule out these acute events. And if after vitals, per abdomen and PV examination, we do not find any of these things, then the first step in the management of pathological CTG is stimulation. We do a PV examination to scalp stimulation. If with scalp stimulation, baby is reactive, then if we can get the accelerations on the CTG, then we are a little bit reassured that the baby is doing fine. Okay.
Yeah.
But with if scalp stimulation also baby is not recovering on the same CTG, pathological CTG is continuing, then we should then the option is to do fetal blood sampling. Okay, so we will ask the senior person like S2 who is ST2 or ST3 who can do the fetal blood sampling, and according to that we will manage and inform. And another thing which I want to tell you that there is another feature that we call we'll categorize the overall CTG into urgent. That is the most means important one that we should always look for. So if the CTG have prolonged deceleration, means 3 minutes, if the deceleration is prolonged 3 minutes or more, if the deceleration is persisting for 3 minutes, more than 3 minutes, then we call this as a means abnormal. This is one of the feature which will categorize the CTG into urgent category. And another one is persistent bradycardia. If the baseline is normal and after some time we can see that the baseline has shifted and now the patient is having means heart rate at less than 100, then we call as a bradycardia, and these two features will categorize the CTG into urgent category. We have to react urgently. We will inform the senior most person and we call for help. We immediately review the patient for any acute event So can you tell me, Anna, what are the acute events we have
Yes,
talked about?
it can be like a cord prolapse or scar rupture or any bleeding, like abruption. Correct?
Oh, very good. Very good. You're a very quick learner. So, Anna, I was telling you, when we have this, then we have to quickly rule out this acute event, start the conservative manner, explain the situation to the patient and her attendant, and tell her there are chances that baby may be, baby may have some problem. So we might need to deliver the baby. So if the patient has features of urgency, we need not to go for any stimulation or blood sampling. We have to expedite the birth of the baby. So in that situation, depending upon the patient findings, if patient is in advanced labor, almost fully dilated, we can deliver her by, depending upon the station of the patient, we can deliver about the instrumental delivery, or if she is not progressed, then we have to do emergency cesarean section to save the baby. Am I clear?
Yes, yes.
Okay, I know it's too much. I have given you a lot of information today, but I will be giving you the written information in the also Start 2G and other web links that you can go through and go through. And if you find any difficulty, you can call me anytime. And whenever I will be in the labor ward and I'll be having good CTGs, I will contact you. So anytime, if you have any any problem in interpretation of the CTG, you can contact me. I will be happy to answer you. So do you have any other question?
No, thank you. Thank you very much.
Okay, have a nice day. Thank you.
You send to you.
Thank you.
Okay. So Bushra, just can you tell me something about your station?
Ma'am, it was teaching station, and I know I am not very structured. I was just telling you what was coming. I
Only
never
the thing,
prepared
yeah.
this
Only the
as
thing. I will tell you. The only thing, yes, you know everything about the CTG, but you know how you don't know
I
how to
know I have
structure
not
it and
means
how to finish it in 10 minutes.
yeah, ma'am. That's the thing. I
You
have
can
not
go on
prepared
for
it like
hours
this.
and
I just
hours talking about CTG.
yeah, that's
Correct?
what I was thinking. Then I
Yeah.
finished. I can.
Yeah. Okay. So you just can go hours and hours talking on CTG, but this is not the thing what we have to do it in exams, correct?
Yeah.
So you know there is no
Ma'am.
problem with your knowledge. A small some 1 or 2 mistakes were there, but okay, that can be this thing. If you read this, but otherwise, see, I have given you 2 CTGs, correct? And in the
Yeah, ma'am.
agenda, sorry, in the beginning only, I told that I know the basic CTG. Correct? I know the basic CTG.
Yeah.
I want to know how we have to interpret it. Okay. So see the teaching while when you talk about the station, yes, introduction was fine. You got the understanding also exactly what the training wants. That also you got it. Okay. That you find out correctly, but then you didn't act it out in that way. Okay. That you know that this training wants regarding this final interpretation of the CTG. Okay, correct?
Yes.
So definitely once it tells you that I want regarding the final interpretation, like I don't know how to categorize them suspicious, pathological and all these things. So I get confused with that.
Okay.
So here what she is more interested in regarding the decelerations and how you're going to categorize those decelerations, because the other features are easy, correct? Other features are easy to categorize.
Really?
Yeah. What you have to talk more about decelerations. Now in variable decelerations, what you did? No, I will. Yeah, my voice is not clear. Is it breaking?
No, ma'am. Clear. For
No,
me,
no.
for me, it is clear, ma'am.
Okay.
For me, it's
Okay,
clear.
no problem. Yeah. So now once she tells you, so here you have to talk. You are expected more to talk on the decelerations parts.
Okay, ma'am.
And once you started talking on variable decelerations, and then you told that I will come to it on later on. So here basically what are the concerning characteristics and all these things that you are supposed to tell. Okay. And when you call it as suspicious and when you call it pathological, there is no need that you should define the acceleration. There is no need that you should define the decelerations or what is the baseline heart rate. Just go on in the flow, telling regarding these basic features, but don't explain too much of it. Okay?
Okay, ma'am.
Got it?
Okay.
Yeah. And
Okay,
then,
ma'am.
yes, management also, I don't think it is very necessary to talk on it. Okay? Because right now, this is a training session regarding the CTG. Okay? Because you
Okay,
can't complete it in 10 minutes. Whole CTG, it's impossible to complete it in 10 minutes. So
That's
in
what I
CTG
was thinking,
teaching
ma'am.
session,
Means
please
which
first
portion I should, which
and
portion I should
foremost,
speak on.
please try to find out. Yes, go on. Yeah.
Ma'am, that's what I was thinking when I started, which portion I have to speak. Means interpretation of the CTG means I have to take everything. Then it was quite big. That was means I could not understand which portion I have to focus.
Okay. Still my voice is breaking because I got 2 messages that voice is breaking. Is it breaking?
Ma'am, for me
Hello?
it is okay. Maybe for others it is breaking, but for me it is okay.
Please, for whom it is breaking, please just please rejoin the session. Okay, please leave and rejoin the session. It will be okay then, I think, because I think it's clear and I can also hear Bushra very clearly. Okay. Yeah. So see, the another thing is I have given you 2 CTGs, so you are supposed to talk on 2 CTGs, correct?
Yeah.
So why I have
Yeah.
given you these 2 CTGs is just because to tell regarding this deceleration and types of decelerations. Okay, 2 different CTGs. Why I have given this is because to tell the difference. Now here trainee's agenda can be different. If she is like foundation year trainee, something like that, then she will want to know more about what is exactly baseline heart rate, what is variability, how to classify accelerations and decelerations. Okay, so that station will become totally different. This station will become totally different. But common to those 2 things is you have to tell regarding the prerequisites of the CTG, correct? Prerequisites of the CTG, what are the limitations of CTG? Got it? And how you're going to do it. So these 3 things will be very common to the both of the stations. Only thing, the interpretation wise, maybe the beginners wants to know more regarding all this, how to do this baseline heart rate, how to calculate this variability and all these things. Okay. Yes, can you hear me?
Yes, ma'am. Actually, maybe because of me, there is some
Okay. There is
noise,
no
so
problem.
I muted
Okay.
myself.
Okay, so I will go on talking. If there is any disturbance, please let me know. Okay. Yeah, with my
Okay.
voice.
Okay, ma'am.
Yeah.
Okay, ma'am.
So now I will go on to the next part that exactly. So just in the teaching station, remember, because CTG teaching is very vast, you cannot complete in 10 minutes unless you find out that what the training exactly wants. So this is the first thing that you should do. And in any teaching station, please do your agenda very clearly in the beginning. Like if you forget regarding, or if you don't get time at the end to mention regarding the teaching sources or learning resources and the feedback, then at least the examiner will mark you on that agenda, okay, that you were about to tell. So always in the agenda. So here the agenda will be, so I will be telling you today regarding how to classify this CTG, because as you know the basic things, I will be telling you what are the prerequisites, what are the limitations of CTG, and I will tell you exactly how to classify this CTG and management. And in the end, I will give you some learning resources like videos and CTGs and the strategy, fetal monitoring, this thing, fetal monitoring module is there. And I will get, then both of us can get feedback from each other. Okay, so this will become your agenda, but you have to tell it in the beginning. For any teaching station, try to complete the agenda in the beginning. Okay, so now once we start this telling regarding the CTG, so first please tell the definition that yes, it is the graphical electronic graphical representation of the fetal heart rate. Okay. Yes, only what she wants, because you can't complete the CTG station in 10 minutes otherwise. Okay, there is too much to talk. So please just get from the trainee what exactly she wants. So now once it is, you have to see that your instrument is okay. So these are the prerequisites. So you have to check your instrument You have to see that your fetal blood sampling facilities are available. In the UK, usually the paper speed can be 1 centimeter per minute or 3 centimeters per minute, but in the UK, usually it is set at 1 centimeter per minute. Okay. And then you should also be sure that the paper in the machine is running freely with adequate supply, because if the paper runs out and if there is any litigation, then it will be very difficult. Okay. Now, make a systematic assessment of the condition of the woman. So never interpret the CTG on the basis, never interpret or never make any decision on the management of the patient only depending on the CTG. You have to take into mother's condition and mother's preferences. Okay. So treat the patient and not the CTG. Always give one-to-one support and tell the woman and birth companion exactly what is happening. Okay. So these are the prerequisites while doing any CTG or acting on any CTG. And what are the basic recording you will do? So you will record the basic demographic data on the CTG, that is identification data, and you have to do the CTG. If you are doing continuous electronic fetal monitoring, you have to at least hourly systemic assessment of that CTG should be done. And if any abnormality is there and you have done the FBS, that FBS documentation should be also done properly. Okay. So all these things you should do. And the limitations of CTG, as it causes this reduced mobility. Then again, the woman may not be in the center of the care. Okay. You will take the decisions depending upon the CTG and not depending on the woman's condition. Also, it increases the interventions. Again, there is subjective variation in the interpretation of the CTG stress. Sometimes chorioamnitis or infection could make the interpretation unreliable, and always litigation is always the limitation. Okay, because there are so many variations in the interpretation. So see, this misinterpretation of the CTG is one of the major reasons for the large numbers of claims. Okay. So it has been shown that there was misinterpretation in 90% of cases. So now once you tell regarding all these prerequisites and the limitations, now you have to go to the how you are going to interpret. So yes, the C bravado that you have to tell in each page for each training. Okay. So how you are going to interpret, you have to tell the C bravado everywhere for any junior trainee or if she wants higher this thing also. So DR is the determine the risk. C, contractions you have to record in accelerations. D for decelerations, and O is the overall impression of the CTG. So first you have to determine the risk. So risk can be either maternal, either fetal, or because placental problems. So maternal problems can be either maternal diseases like heart disease, connective tissue disease, diabetes, hypertension, okay, or it can be due to the epidural anesthesia or because of maternal hypotension or hypovolemia, that is dehydration. Placental factors can be either abruption, cord accidents, it can be infection, chorioamnitis, okay, preeclampsia or FGR. So these can be placental problems or fetal risk factors can be, see the upper risk factors, actually this risk factors they have given in the strategy, but the upper risk factors for instrumental delivery, you are not going to do this CTG, correct, afterwards, because once you are going to do this instrumental delivery, there is once you start applying the instrument, there is no need of doing the CTG, correct. And even for cord prolapse, yes, cord prolapse you will be doing, malpresentations you will be doing, vasa previa also you will be like if it is diagnosed vasa previa, you are taking her straight for the cesarean section, then there will be no role of this CTG. Fetal-maternal hemorrhage, definitely you will be doing. Meconium stained liquor, you will be doing the CTG. Infection, prematurity, FGR, anemia, and congenital anomalies. So all these things, these are the risk factors that you have to mention in this determine the risk. Hello, am I audible? Again, I got
Yes,
the
ma'am,
message
you
that
are audible.
no voice.
No, ma'am, you are
Yes,
audible.
you are audible.
Okay. Okay, no problem. Okay. So once you determine the risk, I think this is very easy. There is no problem in determining the risk. Another most important risk factors in this, you have to classify. You can classify on the basis of these mothers. Intrapartum risk factors are basically these two. These mothers. Okay. So like meconium, oxytocin, oxytocin, temperature, hyperstimulation, epidural, rate of progress, and SPAR. So on this basis, you have to divide this risk factors. Now the next most problem occurs with all of us is we are scared of this table, correct? So we don't know exactly how we have to classify, or sometimes we get confused between these two tables in that nice guideline. So just I will try to simplify it. See, there is basically no problem with heart rate or variability, but the problem starts with the deceleration, where to classify it as suspicious and where to classify it as non-reassuring and abnormal. Okay, so this is the basic problem we have this get. Okay, so now I will tell you how we can do it easily. So now once this determine the risk is over, then we have to see for the contractions. So we have to see for this contraction in 10 minutes. So adequate contractions are 4/5 in 10 minutes. Okay. And tachysystole is more than 5 contractions in 10 minutes. And we have to see for at least 30 minutes. Okay. Averaged over 30 minutes. Hypertonus is single contraction lasting longer than 2 minutes. And hyperstimulation, so there is difference between tachysystole and hyperstimulation. So tachysystole is only limited to the number of contraction, but hyperstimulation is when either condition leads to a non-reassuring fetal heart rate pattern. So either tachysystole or hypertenus, when it causes any abnormality in the fetal heart rate, then it is called as hyperstimulation. And then if hyperstimulation occurs, what are the measures you have to take? So if there is no oxytocin or anything is going on, you can give subcutaneous terbutaline 250 microgram, or you can give IV terbutaline 10 micrograms per minute. Okay, and it has rapid onset of action, which causes reduction in uterine activity in almost 87% in the next 15 minutes. Okay, so this is highly powerful drug. And another thing is, you have to, if the oxytocin is going on, you have to stop the oxytocin. If you have inserted any vaginal prostaglandins, you have to remove it. Okay, so this will be the management for any hyperstimulation. So this you have to remember while describing any CTG. Then baseline heart rate when it comes. So it is estimated over a period of 5 to 10 minutes, and you have to exclude accelerations and decelerations, and then you have to interpret it in the beats per minute. Okay, and the normal is 110 to 160. Okay, and you have to also note that this baseline rate at the beginning of CTG, because sometimes the gradual rise or gradual fall in the baseline also, the both can be suspicious things. Okay, so you have to take this into the consideration when there is change in the baseline also. So we have to keep on the eye on that also. Yes, Sina, which slide you wanted? This one, Sina? Hello?
Hello, sorry, Dr. Mrudula.
Yes, Sina.
Limitation. No, just limitation, if possible, to put the slide for limitation.
Okay, limitations. 1 minute. Yeah, this one. Correct?
Yeah. Thank you. Just once.
Yes. You just tell me when yours is.
Yeah. Okay. Thank you.
Yeah. Okay. Great. Okay. So now I will tell you exactly how you have to classify it into reassuring, non-reassuring, and abnormal. So here, Bushra, you made a small mistake. That non-reassuring is, so reassuring, as all of us know, it is 110 to 160 bits. Okay. Non-reassuring is either 100 to 109 or 161 to 180. And abnormal is below 100 and above 180. So 161 to 180, it comes under non-reassuring. Okay, it doesn't come under abnormal. Up to 180, it becomes non-reassuring. Above 180, it becomes abnormal. Okay, so you should know exactly what is. So this is for the baseline heart rate. Okay. Now variability. So variability, you have to analyze for 1 minute portion. Okay, assessing the amplitude in the change of heart rate. And here you have to also exclude any accelerations or decelerations. Okay, and then you have to calculate it from highest rate to the lower rate in that 1 minute. Okay, so see, these things you should not tell in the current station, because she knows all these things. So you should not tell how to calculate the variability and all these things. Okay, because she is knowing now, she wants to know exactly only this interpretation of that. Like foundation year candidate, or if the patient wants the basic, but if the $25. So remember these two figures so that it will be easy. So 5 more, less than 5, more than 50, or more than 25, more than 25 minutes, it becomes abnormal, and in between that it becomes non-reassuring. Remember when, and any sinusoidal pattern is abnormal. Okay, so clear for this variability.
Hello, ma'am.
Remember
Excuse
these
me.
two numbers, 5 for 50 and 25 for 25.
Hello, ma'am.
Hello, Doctor. Your voice is breaking.
For abnormal things. Okay, is it okay?
Doctor, we have not listened, heard
Yeah.
anything of variability. Please, can you repeat again?
Hello. Hello.
Yes, ma'am. We
Am I
can hear
audible?
you. Yes, you're audible.
Yeah. It's clear? Clear
Yes,
now?
ma'am.
Is it clear?
Yes, ma'am.
Yeah. Now it is clear. Yeah, clear.
Okay. It's actually there is lot of winds going on outside. Okay. So is the variability part clear to you, or should I repeat? There my voice stopped, I think. So variability, remember only two numbers, that is 5 for 50 and 25 for 25. Okay, so more than that it becomes abnormal. So less than 5 for 50 minutes and more than 25 for 25 minutes, it becomes abnormal. Sinusoidal pattern is always abnormal, and in between these two, it is non-reassuring. Okay, so clear?
Hello, ma'am.
Yes.
Hello, ma'am. Ma'am,
Yes,
shall I explain these all these things in my station or not about these details of variability?
Yes, details of variability means no need to tell regarding how to calculate the variability, but you have to mention that what are the non-reassuring and abnormal, because on that only you are going to classify it as suspicious or pathological, correct? Depending upon these features only. So what you were telling that you have to classify these 4 features as reassuring, non-reassuring and abnormal. So actually that trainee should be clear regarding variables. That means the variables of CTG you are classifying at reassuring, non-reassuring and abnormal, and overall CTG you are going to classify it as normal, suspicious and pathological. Okay, so it should be clear in her mind. Okay, so what is CTG you are not going to classify it as abnormal or non-reassuring, correct? But that the variables you will be classifying it as reassuring, non-reassuring and abnormal, and CTG you will be classifying as normal, suspicious and pathological. That you should stress on her basically.
Okay, means I need not to tell her about the how we take baseline heart rate variability, just what are the classifying features, how we classify each variable.
Classifying features,
that
yes.
I know.
And for got it. And for that you have to take help of those CTGs. Okay, what you did, you told everything and then you started with the CTG interpretation. Okay, so you have to do it simultaneously, because now she understand what is baseline heart rate, she understand what is variability. Okay, and you can confirm with her whether she understands or not. You can ask her what is baseline heart rate here. Okay, so that you will come to know.
Okay, thank you, ma'am.
Yes, Vijayalakshmi, these values are given in the NICE guideline only. Okay, NICE guideline only, they have given these values. Only thing I have made these slides only to simplify it, because they have given it in that big table. So we usually get scared with that table. Okay. So now, as I told you, always sinusoidal pattern is always abnormal. So what is the sinusoidal pattern? So these are smooth undulating sine wave like baseline, and variability is absent in this sinusoidal pattern. Usually this undulation amplitude is between 5 to 15 beats and frequency is around 2 to 5 minutes. Okay, while when the sinusoidal tracings where these oscillations have amplitude of 20 beats or more and frequency is 1 to 2 oscillations per minute. Okay, so that means it is a prolonged thing. So it is more suggestive of fetal hypoxia and it is an indication for immediate delivery. Sinusoidal traces where the amplitude is 10 beats or less and more frequency. So it is usually due to fetal anemia or thumb sucking, and these are known as pseudo-sinusoidal. So here you can see the CTG. So you will understand that. So here see amplitude is less. So amplitude is around hardly 5 to 10 beats, and the magnitude, so this frequency is also 4 to 5 beats. Correct? 4 to 5 oscillations per minute. So that means this is pseudo-sinusoidal. Okay, this is pseudo-sinusoidal. This can be either due to fetal anemia or thumb sucking. Okay, but so this pseudo-sinusoidal, it does not require immediate action. But if other heart rate abnormalities, so other abnormalities are present along with this pseudo-sinusoidal, then delivery should be required. Okay.
Excuse me, ma'am. Can you please explain this pseudo-sinusoidal again,
CTG,
ma'am? What is the difference? No.
Yeah,
What is the difference between sinusoidal and pseudo-sinusoidal? Is they are two different things or the same thing?
These are two different things. Okay, so pseudo-sinusoidal is because of fetal anemia, and sinusoidal, these are because of fetal hypoxia. Okay, so actually I don't have a sinusoidal proper trace here today, but I will just post it in the group. Okay, what is exactly the sinusoidal trace? See this trace, you can see the amplitude, see the oscillation, number of oscillations, they are almost 1, 2, 3, 4, 5 in 1 minute oscillations. Okay. And the beats is between 5 to 10 bits only. These are not, amplitude is not more than 10 bits. Got it? 5 to 10 bits is there. So these are pseudo sinusoidal pattern. This is okay. And this might be due to fetal anemia. While if this you can see, this is like what we can say, this proper sine wave pattern will be there. Larger amplitudes are there, then it is due to fetal hypoxia. Clear?
Okay, ma'am. Thank you.
I will post that sinusoidal pattern in the group. Okay, I think today I don't have that, but still I will. Okay, I will post it in the group. Now, acceleration, as we all know, the acceleration is 15 beats or more and lasting for 15 seconds, at least 15 seconds. Accelerations are due to because of usually fetal movements or uterine contractions. When the accelerations are present, it is usually a reassuring sign, even in the presence of decreased variability also. Okay. But when the accelerations are absent or an otherwise reassuring CTG significance is uncertain, but so see, when there is accelerations are not there and when there is decreased variability, so it is usually suggestive of hypoxic response. So there are no accelerations, there are no deceleration, and variability is decreased. So that is because of fetal hypoxia, okay, or increase in the baseline heart rate. That is because of usually fetal hypoxia. So before labor, if you find the CTG like this, that is, there is no acceleration, no deceleration, decreased variability, and increased baseline heart rate or fetal tachycardia, that is usually because of fetal hypoxia. Now, here is the most important thing. So in this station, Bushra, you are more about, you should have explained more regarding this decelerations. Okay? More regarding this decelerations, it is early, rate, variable, and prolonged. Okay? Because depending on these only, you are going to classify the CTG as suspicious or pathological, correct? So how you have to classify the decelerations is, so decelerations can, 1 minute, I will start the slideshow. So decelerations, these are usually classified as early, late, and variable. So early, these are how you're going to find out this early deceleration. These are mirror image of contraction. Remember very well that these are mirror image of contraction. So the CTG, what you have seen earlier, that second one CTG, we will go to that later on again. So these are the early deceleration. These are the proper mirror image of the contraction. Okay, they are usually uniform in size, shape, and duration, and generally seen in late first or second stage of labor. Okay, these are due to head compression and early decelerations. These are not any ominous feature and these are reassuring. Okay, so presence of early deceleration is not at all suspicious, sorry, not at all a non-reassuring or abnormal feature. Got it? So this is regarding early decelerations. Variable decelerations, remember well, these are not related to contractions. So you can't classify depending upon the contractions. These are unrelated to contractions. These are due to cord compressions. So variable decelerations, what we have to see is whether there are any concerning characteristics or not. And we will come to that in next slide, what exactly are concerning characteristics. But here you can see these are unrelated to contraction. It can come either before contraction or after contraction or during the contraction. Okay, so these are the variable decelerations. And the late decelerations, remember here the trough occurs after the end of contraction. So this deceleration of Hello. Yeah. Can you hear me? I'm sorry, dears. Today it's causing really lot of disturbances. Can you hear me? Hello.
Yes, ma'am. Now we can hear
Can
you.
you hear me? Yeah.
Yes,
Okay.
ma'am. Yes,
So
ma'am.
yes. Yeah. Okay. Yeah. Thank you. So these are these basically concerning characteristics of this variable deceleration. So first you can see this is the basic variable deceleration. Yes, Isha. So this is the basic variable deceleration. So it has the shouldering before and after the deceleration. Remember, well, every deceleration has the shouldering before and after this deceleration. So this is the first thing, that is loss of shouldering will be there. Okay, loss of shouldering will be there, or there will be exaggerated shouldering. Okay, exaggerated shouldering. There will be delayed recovery. That is it takes more than 60 seconds to recover. Okay, so it can characteristics. Lower baseline. So baseline before the deceleration was different and baseline after the deceleration was decreased. That is a sound tachy characteristic. That is increased baseline after the deceleration, or late component.
Dr. Mrudula, your voice is not heard. Please.
Deceleration. Okay, so it has two components, or biphasic deceleration. So it becomes the concerning characteristics. Okay, so these are all concerning characteristics of variable deceleration. Any variable deceleration, okay? Failure to so
Hello.
am I audible?
No, Dr. Mrudula,
So I
we
think there is a
couldn't hear
problem.
you anything. No.
Please repeat this variable decelerations again, ma'am. You're not at all audible.
Yes. Yeah. Can you hear me?
Yes, ma'am.
Hello?
Yes,
Yes,
Can you
ma'am.
hear me now?
yes, ma'am.
a lot of interruptions.
Okay. Yeah. Okay. No problem. Yeah, I'm so sorry for that, but I can't help it. Okay. So,
Can you please repeat
so
the types of
yeah,
variable
variable
acceleration?
deceleration.
Variable
Yeah,
deceleration.
this previous slide, this one, no?
Yes, ma'am.
Yeah. So variable deceleration, see, there is the shouldering before variation, before deceleration and after deceleration. Okay, so this is the normal variable deceleration. Now, what happens with this concerning characteristics? Either there is loss of shouldering, either previous or after. There will be exaggerated shouldering, or there can be delayed recovery. That is, it takes more than 60 seconds to recover the deceleration. There will be change in the baseline. So either it can be lower baseline or upper baseline. That means either bradycardia or tachycardia, or there will be the change in the heart rate baseline. Previous baseline, either it will be more or less, or late component or biphasic deceleration. It has got the W shape. Okay. So these are the Concerning characteristics, I have just given the description of it. So it is lasting more than 60 seconds, reduced baseline variability within the deceleration, failure to return to baseline, biphasic, or no shouldering. Okay. And then the last type of this deceleration is prolonged deceleration. So it is a drop in the fetal heart rate of minimum 30 beats. Okay. So 30 beats from the baseline or more. It should last at least 2 minutes. Okay. So according to definition, it is for prolonged deceleration is called if it is more than 2 minutes, but action will be taken. So action, it will be concerning if it persists for more than 3 minutes or longer, then plan should be made to expedite the delivery. Causes of this prolonged deceleration, so either acute insults like cord prolapse or scar rupture or abruption, okay, or other causes which can reversible. Reversible causes of prolonged deceleration are maternal hypotension like epidural anesthesia or uterine hyperstimulation. Okay. Also, prolonged deceleration can occur after artificial rupture of membrane, maybe because of any like when the pressure is applied on the fetal head, which causes the vagal center stimulation. Okay, so this can be also one of the cause of this prolonged decelerations. So now when you have to take the action for this prolonged deceleration is, so what happens in acute hypoxia, like these three events, what I told you, abruption, scar dehiscence, or cord prolapse, these are the three most important acute events. There will be prolonged deceleration for less than 80 beats per minute. So when this deceleration reaches up to 80 beats per minute and it is prolonged, it will be usually because of acute hypoxia. And reversible causes, as I previously told you, because of hypotension, hyperstimulation, or any vaginal examination. In more than 50% of cases, there is no cause is identified. So acute hypoxia, you may get either this single prolonged deceleration, okay, so more than 3 minutes. Sometimes you get prolonged decelerations which are lasting for more than 3 minutes. So they will be repeated deceleration, but they are getting usually recovered around 3 minutes. Or there will be prolonged baseline bradycardia below 100 beats per minute over 10 minutes. Okay, so it is a prolonged baseline bradycardia. So all these three, these are maybe due to acute hypoxia. And what happens in acute hypoxia? This pH drops at the rate of 0.01 per minute. So see, this is not expected from you in the station, okay, in any teaching station. I am just giving you some extra information. So in this thing, only thing you have to interpret the CTG. So we will come to that interpretation. But only thing, along with this prolonged deceleration and all these things, I am giving you this extra information also. So when with any prolonged deceleration, yeah, if the acute events are excluded, then you can wait. Okay, you can wait and you can see whether this becomes normal. Okay, if the CTG prior to deceleration was normal, then you can wait and you can see if there is it gets recovered. Okay, but reduced variability prior to onset of bradycardia, this is usually associated with poor outcome. So before any prolonged deceleration, if there is any reduced variability is there, then usually outcome will be poor. Okay, and when these three causes are ruled out, okay, so over 90% of this CTGs with prolonged bradycardia, they usually recover within 6 minutes. Okay, and up to 95% they recover within 9 minutes. So this is basically rule of 3, 6, 9, and 12. Okay, so this is the rule of 3, 6, 9, 12. So what in 3 minutes, what you are expected to do? Urgent, call the doctor. So if the midwife is monitoring this patient, she has to call the doctor, duty doctor who is there, whether it is ST2, ST3 or ST5, whatever. Urgent medical aid should be sought if the fetal bradycardia lasts for more than 3 minutes. Within 6 minutes, if still the bradycardia is persistent, you have to prepare this patient for urgent delivery. Okay, it can be either prepare for instrumental delivery or shift the patient to the theater. In the 9 minutes, if this fetal heart rate is not recovered, then again you have to deliver. Okay, so you have to deliver. So you have to start this thing. Okay, start taking action for this delivery, either assisted delivery or category 1 cesarean section. Okay, so assisted delivery you can do when the woman is in second stage of labor, or when you feel that this baby can be easily delivered vaginally, or category 1 cesarean section when the woman is in still first stage of labor, and easy vaginal delivery is not anticipated. Okay, if the fetal heart rate it recovers within 9 minutes, then the decision to deliver should be reconsidered in conjunction with the woman if reasonable. So here you have to take into account other factors like woman's wishes. You have to inform your senior obstetrician. You have to evaluate again for the risk factors, and if you feel she can again wait, then you can wait with continuous fetal monitoring. Okay, if it recovers within 9 minutes, and if it doesn't recover within 9 minutes, the delivery should occur within 12 minutes. Okay, so delivery should occur within 12 minutes. So this is the rule of 3, 6, 9 and 12. Got it? So 3 minutes, first you will call for help. 6 minutes, you will prepare the woman. 9 minutes, you will take the decision and you will start acting on it. And 12 minutes, the baby should be out. Okay. So now the next here is, so now this is the important slide. This is all of us are scared of is. So what is how you are going to classify these decelerations, either as reassuring, non-reassuring or abnormal. Okay. So see first the early deceleration, it doesn't come in the category of either non-reassuring or abnormal. So leave those early decelerations first of all. Now you have to see for this late deceleration. As we all know, late decelerations are almost always abnormal or almost always pathological for that matter. So late deceleration will go to the abnormal thing only. Any late deceleration will go to the abnormal thing. Only exception is if it is less than 30 minutes. So when late deceleration occurs for less than 30 minutes and they are again recovered, then it becomes non-reassuring. Okay. So only part which is late deceleration part, if it is less than 30 minutes for more than 50% of contraction, this is only for the non-reassuring. Otherwise, all late decelerations are abnormal. Okay. So any late deceleration more than 30 minutes becomes abnormal. Now here again this crux is there with late deceleration. If it is for less than 30 minutes also, sorry, if it is for less than 30 minutes also, but when it is associated with risk factors like vaginal bleeding or significant meconium. Okay, if it is associated with vaginal bleeding or significant meconium, when these late decelerations are present for less than 30 minutes also, it becomes abnormal. Okay, so clear for this late decelerations. So late decelerations less than 30 minutes, it comes under non-reassuring, while if they are associated with risk factors, so for less than 30 minutes also it becomes abnormal, and all other late decelerations for more than 30 minutes becomes abnormal. So clear for late decelerations. So now the another thing is what we are going to classify is variable decelerations. So variable deceleration when they are typical. Okay, typical means normal variable decelerations. So when the normal variable decelerations up to 90 minutes, these are reassuring. When they are typical variable decelerations, when there are no concerning characteristics, up to 9 minutes, these are reassuring. Now, if this normal variable deceleration, they are more than 90 minutes, then it becomes non-reassuring. Okay. Now, when it comes with any concerning characteristics, so any concerning characteristics more than 30 minutes and more than 50% of contraction, it becomes abnormal. So variable deceleration with any concerning characteristics more than 50% of contraction, more than 30 minutes, okay, it becomes abnormal. And in between these two rise the reassuring. That means any concerning characteristics up to 50% of contraction for more than 30 minutes, this is reassuring, or with concerning characteristics more than 50% of contraction for less than 30 minutes, these two are non-reassuring. Okay. So this is the thing that you have to remember and that you have to revise. Okay, before your exam, these are the only these two tables that you have to revise. Other every and each and everything you can remember. So this you should remember what you have to revise just before the exam. So this is the only thing that you have to revise before the exam. So exactly which variable decelerations are non-reassuring and which variable decelerations are abnormal. This is the only thing. Okay. So reassuring variable is when variable decelerations, critical variable decelerations more than 90 minutes. Okay. When the variable decelerations are up to 50% of contractions or less than 50% of contractions for more than 30 minutes, or variable deceleration more than less than 30 minutes but more than 50% of contractions. Okay, so any concerning characteristics, variable deceleration, this thing, only thing you have to remember, you have to read it repeatedly. I will repeat this. You have to read this repeatedly. Okay, there is nothing difficult in understanding, but it is difficult in remembering. Okay, so only this is the thing that you have to practice. That is remember and memorize. Okay, this is the thing. Otherwise, all other things in CTG are easy. Okay. Now, one more thing you have to keep remember is if the baseline heart rate is still between 100 to 109 and there is normal baseline variability and there is no decelerations, that is no variable or rate deceleration, it is a normal CTG. Okay, it is a still normal CTG. It doesn't become suspicious. Okay. So when other features are normal, baseline heart rate between 100 to 109 is a normal thing. So now we come to the overall impression of the CTG. So O of this, Dr. Sri Bravado. So O of this thing, you have to classify the CTG in the normal, suspicious, and pathological. Okay. So normal, all features reassuring becomes normal. We all know. Suspicious, only one non-reassuring feature makes the CTG suspicious. And pathological is one abnormal or two non-reassuring. Okay. So this is the overall impression. We all know, only thing we sometimes forget what is how we are going to classify the CTG and how we are going to classify the features. So always remember, features we will be classifying according to reassuring, non-reassuring, and abnormal. And overall CTG we are going to classify it as normal, suspicious, and pathological. Okay. Now, how you are going to interpret this intrapartum CTG? How you are going to interpret this intrapartum CTG? So whenever you are reviewing any CTG, you take into account all four features, that is baseline heart rate, variability, absence and presence of decelerations and accelerations. Okay. If there is baseline heart rate is 110 to 160 and variability is normal, continue the usual care. Okay. If there is any difficulty to categorize or interpret the trace, take the opinion of the senior. Okay. If the acceleration are present, if there is, but with reduced variability, still it is a reassuring feature only. So if the accelerations are there and somewhat reduced variability is there, still it is a reassuring feature. So you should always remember while interpreting the CTG as a whole. Okay. Now, normal CTG management, as Bushra told correctly, continue the CTG if it was started because of any risk factor. Okay. If it is started because of any risk factor, continue the CTG. But if you have started the CTG just because intermittent auscultation, you are doubtful about some fetal heart rate patterns, like if intermittent heart auscultation, you find some bradycardia or something, then you can discontinue the CTG. Otherwise, if any risk factor is there, you have to always continue this electronic fetal monitoring. Talk the woman and her birth companion regarding what is happening. So this is normal CTG management. Now suspicious CTG. So for any suspicious, you have to correct underlying cause like hypotension, hyperstimulation, or any pyrexia. Okay. Perform a full set of maternal observation. Start one or more conservative measures. So we will come to those conservative measures later on. Inform the obstetrician and senior midwife. Document a plan for reviewing the whole clinical feature and CTG findings, and always talk to the woman and birth companion. Okay. So this is for the suspicious CTG management. Now, what are these conservative measures? When we always talk about with any CTG management, we always talk about these conservative measures. So what are these conservative measures? To encourage the woman to mobilize or adopt an alternative position. Avoid being supine. So we can keep the woman on left lateral position or change the position. Offer intravenous fluid if the woman is hypotensive. Reduce the contraction frequency either by reducing or stopping oxytocin, or you can offer any tocolytic. Okay, that is terbutaline 250 micrograms subcutaneously. So this is the suspicious CTG management. Now, how you're going to manage this pathological CTG? So always first inform or get a review by senior obstetrician or senior midwife. Exclude any acute events. So acute events like these three: cord prolapse, rupture, or abruption. Correct any underlying causes. Hello? Am I audible? Hello? Can you hear me?
Yes.
Yes, yes.
Yeah, okay. Yes, okay. So you have to correct any underlying causes like hypotension or hyperstimulation, like you have to give IV fluids or tocolytics. Start conservative measures, talk the woman and her birth companion. Now, if the CTG remains still pathological after conservative measures, again further review by obstetrician or senior midwife. You have to offer scalp stimulation or scalp electrode, okay, and document the outcome. So if you find accelerations and improvement of CTG, you can again continue with this fetal monitoring. If still it remains pathological after fetal scalp electrode, you have to consider either fetal blood sampling or consider expediting the birth. Okay, so now these two are alternating. Remember well, fetal blood sampling and birth. So when the patient is in the like in second stage and she can deliver within no time, so you can go for expediting the birth. Now then you should not wait for any fetal blood sampling. Okay, like if you can do instrumental vaginal delivery, then you should go for that. Okay, then you should not wait for any fetal blood sampling if she is in second stage. And or else if she is in the first stage or there is still time for her delivery, then you can go for fetal blood sampling. Also, you have to take the woman's preferences. Okay, so see for the woman's preferences also in that thing.
Excuse me, ma'am.
Now this is, I think this is, yes, go on.
Ma'am, can you
Yes,
please
who is that?
repeat slide number 39 and 40, suspicious CTG management?
1 minute. This one? Yes. So yes, here you have to take, first you have to see, show any senior obstetrician or midwife, you have to review it. You have to correct any underlying causes like hypotension or hyperstimulation. You have to perform a full set of maternal observation. So to see that whether maternal tachycardia is there, any fever is there. Start conservative measures, okay? Document the plan for reviewing the whole clinical picture. So you have to make a good documentation, and in any CTG you have to talk to the woman and her birth companion regarding what is her preferences and what is happening, okay? So what are these conservative measures? Is change the position, second is IV fluid, and third is the tocolytics or stop the oxytocin. Okay, so these three are the conservative measures. So pathological CTG management is almost similar to the suspicious one. So if this CTG doesn't become a normal after this conservative measures, then you have to apply fetal scalp electrode. Okay, fetal scalp or digital fetal scalp stimulation, and see if CTG becomes better. If it doesn't, if it remains still pathological, then you have to do either fetal blood sampling or consider expediting the birth. So it is not always that first go for fetal blood sampling. You have to assess her condition. If her delivery is imminent, go for expediting the birth, or if the delivery is not imminent, then go for fetal blood sampling. Okay, and always take the woman's preferences also in consideration. Now this is some extra information what the STRAT OGOI has given just for your information. Okay, so how this CTG exactly deteriorates. Okay, so first when the normal CTG is there, all reassuring features are there. So how deteriorates timely. So first what happens is first occurs presence of deceleration without a rise or in baseline or any reduction in baseline variability. So it is considered as a stress pattern. So baby has got somewhat stressed inside or some hypoxia has started. So it will be, so first will be presence of deceleration, but there will be no change in baseline or there will be no reduced variability. Okay, so this is the first things that the fetus has started with some hypoxia. Okay, then the next thing occurs is de-stress pattern. Okay, stress to de-stress. So when this hypoxia develops gradually, then first thing is accelerations will go off. Now when the oxygen requirement is still not met, then there will be rise in the baseline up to the maximum possible, and then followed by reduction in the baseline variability. So variability reduction is due to autonomic nervous system hypoxia. Now, next, the fetus has no capacity to increase any stroke volume or cardiac output. So here there will be release of catecholamines, and it will again, so it will cause this rise in the baseline heart rate and reduction in this baseline variability. Now, if this intervention is not done, then there will be start this collapse pattern. So collapse pattern, it will first the fetus reach to the maximum tachycardia, that is 20 to 30 beats above the previous baseline, and baseline variability is reduced up to less than 2 beats per minute. Then next thing is the heart rate will start declining. Okay, so there will be a state line state-wise manner. The fetal heart rate will start decreasing. Okay, and then it is called as, so slowly it will become terminal bradycardia. So it is called as horn step ladder pattern. Okay, so it is called as horn step ladder pattern. This is the from deceleration, then baseline tachycardia, then reduced variability, and then bradycardia and terminal bradycardia. Okay. Now, what happens in long-standing hypoxia, like in FGR fetuses? Okay, so before onset of labor only, there is some hypoxia will be there. So in those fetuses, what happens is basically the variability will be very less. Okay, this is less than 5 beats per minute, or sometimes it will be less than 2 beats per minute. Okay, and then what happens? There will be shallow deceleration. Okay, so shallow deceleration with variability less than 2 beats per minute. So this is a chronic hypoxia pattern. Okay, so there is no need to, I think it is not important according to your station wise, but just for your information I am telling this. So this is the chronic hypoxia pattern what is given. And another thing is how when there is reduction in variability, it may be because of sleep pattern also. So in these things, they after some time, that is maximum, the variability can be reduced up to 90 minutes, because fetal sleep cycle is maximum up to 90 minutes. So there will be usually recovery after the 90 minutes. Then this fetus sleep cycle is gone. Okay. So now subacute hypoxia also can occur. So subacute hypoxia, what happens is there will be a difference in, so deceleration, when the fetus, the time spent in deceleration and time spent in normal baseline, when there is proper mismatch between this time spent in deceleration and time spent in normal baseline, so when this time spent in normal baseline become very less, okay, so there will be no wash off of this carbon dioxide, so there will be subacute hypoxia will develop, and it will be also again it will cause finally terminal bradycardia. Okay, so now I will try to interpret few CTGs. So now you are going to answer these CTGs. So I think we will go, anybody who is going to, you have to describe the CTG in C Bravado Dr. C Bravado format. So first, anyone wants to go with the CTG? First CTG who will do? There are 10 to 12 CTGs.
Can I do, ma'am?
Okay, who first is Megha? Yes, Megha. One minute. Megha, I thought I read the first message. Megha. Second one is Shraddha. Okay, so first go, Megha, go on. Yeah. Megha? Are you there? Megha, can you hear me? Guys, can you hear me? Hello?
Yes, doctor. Yes, we can hear you.
Yes, ma'am.
Yeah. Yes, and where is Megha? Okay. Megha. Okay, so Megha is not there. So who is next? Shraddha.
Yeah, I'll do it.
Shraddha, yes, you can. Yeah, do. Go on.
How many
Only
minutes
Dr.
will
C.
it take?
Bravado, nothing more than that.
Okay.
No minutes. Only just go on describing Dr. C. Bravado. Only 30 you have to do. Okay.
So this patient, we have to determine the risk of the patient. We need to know what are the background risk. We need to know any maternal risk, fetal risk, or placental risk.
Shraddha. So now there is no risk factor. So here in all CTGs, forget about the risk factors not given. You can tell not given and go on to the next. Okay.
So this is an adolescent CTG. So we have determined the risk factor. Then we have to see whether the patient entry, the details of the patient has been entered. We can see the paper speed. It is 1 centimeter per minute. Then we have to see the number of contractions.
Shraddha, I don't want anything. I just want Dr. C. Bravado.
Okay. So the number of contractions in 10 minutes, we can see just there is 1 contraction. Then we have to see the heart rate. So the heart rate is around, it is, if we see the baseline heart rate, it will fall around 130, 140 to 150. Around 145 is the heart rate. The variability throughout is more than 5. And there are accelerations also. There are 1, 2, 3, 4, 5 accelerations. So overall, this is a normal CTG because it has no abnormal or suspicious features.
Okay, good. Only thing here, the baseline is around 140 to 145. Okay, it is C. You can see around 140 to 145 is the baseline. Okay, this is line is 140 line. Okay, yeah. Okay, so next one, Vishnu Priya.
Thank you, doctor.
Yeah. Okay, good. So this is a normal CTG. Okay, accelerations are there. Baseline variability is between 5 to 10 bits. Okay. So next CTG, Vishnu Priya.
Can I do?
I think here. Okay, please give me
Mrudula.
your this thing, my dear. Yeah. Okay.
Yes, Mrudula.
Vishnu Priya, go on. Yeah, go on.
Yeah. This CTG shows the baseline being 80 beats per minute, and sorry. Yeah, according to the Dr. C. Bravado, we need to define the risk, and the contractions are not that adequate, and baseline rate is baseline rate is 80 beats per minute, because most of the beats are touching at 80, around 75 and 80.
See, my dear, here the baseline here is 140. Okay, it's around 130 to 140 baseline here. Okay. Okay, now go on to the next. Yes.
Yeah, baseline is around, that's what I got confused, whether it's the lowest trough we are taking or okay. Yeah, the baseline rate is around between 130 and 140 because most of the beats are touching here, and there is that is the baseline heart rate, and beat to beat variability is between 5 above 5 only, around 5 to 10, and there are accelerations. We can't say exactly there are no accelerations, and there are decelerations. It is going up till 80. So it is we can say it is a pathological CTG because there are one abnormal feature. One abnormal feature, that is one abnormal feature or 2 non-reassuring features also we can take. It is overall impression is the pathological CTG.
How will you classify these decelerations?
Yeah, this decelerations if we take the baseline as the 140 to 150, these are like variable decelerations.
Any
because the
concerning
contractions are
characteristics
not
are there or
adequate
not?
to concerning characteristics. Yes, there are there. There are the concerning characteristics that is a W shape and biphasic and then shouldering is there.
See, Vishnupriya, actually, see, these are the variable decelerations, okay?
Yes,
but
yes.
one thing is there, these are not W-shaped. This is the baseline variability between the decelerations. Okay?
That is baseline variability, but above
this is the baseline
peak
variability in the decelerations. It is having normal baseline variability. And peak, this is shouldering is there. Shouldering
baseline
is there,
variability is
a
normal.
Feature, okay? So, yeah.
Concerning
and shouldering
feature.
is there. That
shouldering
means it is a good
there.
feature. Okay.
Yes.
So there is no concerning characteristics here. Remember well, there are no concerning characteristics. These are typical variable decelerations, as you can see.
Yes.
So this CTG becomes only one non-reassuring feature is there. And still we have not crossed it for 30 minutes also. So here we cannot say it is non-reassuring. Correct? You have to continue for 30 minutes to see that it is
we need to continue for 30 minutes. Yeah.
90 minutes.
Yeah.
For 90 minutes, you continue it to say it is non-reassuring. So still this becomes a normal CTG only. Got it?
Okay.
Because these are variable
Dr.
deceleration,
Mrudula?
but these are typical. There is no concerning characteristic. Yes. Yes.
Excuse me, Dr. Mrudula. Yeah, Dr. Mrudula, I don't see any contractions over here. So actually we label the decelerations according to the presence of contractions. This I would label as a spontaneous decelerations, and maybe the patient is not contracting. So I would consider
she
it
may
as
not
like
be in
a
labor
normal.
also.
Yes,
there are no
exactly. This is my point.
She may not be in labor. Yeah.
Exactly.
She may
so
not be in labor.
Dr. Mrudula, this would be the worst CTG. The patient is having decelerations without contraction.
There are
even
no contraction.
even without in labor, she's having spontaneous deceleration. Even though she's not in labor, she's having spontaneous deceleration. Exactly. That's what I was seeing down the contractions.
But if you go with this Dr. C. Bravado, it is you cannot describe this as pathological. Okay, this is actually a hypoxic CTG.
Yeah.
And this piece.
Oh, okay.
He needs intervention, doctor.
But on the C. Bravado, you can't classify it as pathological. Yes.
Yeah, C. Bravado will actually refer to the CTG, not the NST. This looks like a non-stress stress.
Yes.
Like when we talk of the patient is antenatal and not intrapartum.
Antenatal. Non-stress.
So before induction,
it is a non-stress.
If it is for
before
FGR,
induction.
actually this is a stratogy CTG. They are defining for this, I think, for FGR or something like that. Okay. So before the induction, if the CTG is like this, then you cannot induce this patient. Okay.
True, doctor.
No,
yes, actually, one more thing, Mrudula here, we cannot say as variable deceleration and concerning features also. That's what I got confused. Where is the base? Anna? We can't mention as variable also because that contraction.
Variable also.
Yes. Okay. Thank you.
Yeah.
Thank you.
Hello,
Dr.
Then how here means then what is the category? Is it a normal or suspicious CTG?
It will be pathological.
No, it is hypoxic only, but we need to continue and see. We need to continue and see over
according to NICE, how we are going to classify this? There is nothing like hypoxic. No, we have to classify either normal, suspicious, or pathological.
No, Bushra, this is not CTG at all. It is not with respect to contraction. So it is NST rather than CTG.
No.
Wait.
Excuse me. Can I clarify this?
Let me talk. Shall I go on? NICE interpretation is for intrapartum CTG. Okay. The NICE guideline which is there, it is for intrapartum CTG interpretation. Okay. And if you are doing it for induction, then you should not do the induction with this CTG. Okay. This is a hypoxic CTG. Yes. Now Anjali, go on.
Doctor, First of all, I would like to say that as you clarified, this is not an intrapartum CTG, but still the decelerations are variable only because they don't have any relation to the contraction. Secondly, you just now described in your explanation, I have read it in a book also, this is subacute hypoxic pattern in which the baseline and the decelerations are almost equal because there is no standard baseline, and again decelerations are coming. Broad-based decelerations are there. So this patient actually needs urgent delivery. This is a subacute hypoxic pattern with variable decelerations because there's no standard baseline in this CTG and there's nothing like hypoxic CTG. It's a pathological CTG. We need to do urgent delivery for this case.
Okay.
Hello, hello, Mrudula.
Yes, Sina.
Yeah, this is considered pathological if you follow the concern of variable deceleration, that it is drop more than 60 minutes and lasting more than 60 seconds. And regarding to this CTG is less than 30 minutes and it is a drop more than 60 and lasting more than 60. So this is pathological.
Yeah, yes. Now what we are telling it, this is not intrapartum or it is in the absence of this thing, contractions. Okay. So here basically without any contraction, she is having these decelerations. Okay. So that means she needs delivery. The baby is hypoxic inside. Okay. So just on the basis of intrapartum CTG, we can't classify on the C bravado characteristics in this. Okay. In this CTG. Got it?
Yeah, clear. Thank you.
And one more thing, the CTG, if it is falls under for 90 or 90 beats or 80 beats, it is not concerning. Basically, it should recover within 2 minutes. Okay, or sorry, delayed recovery is a concerning characteristic. More than 1 minute recovery, it is a concerning characteristic. Okay, but fall of 80 beats or 90 beats, according to new NICE, there is no that it is a concerning. Okay, if it falls up to 60 also, or if it falls up to 90 beats also, it is not a concerning characteristics. Okay, depending upon the new classification. Only thing, delayed recovery is a concerning characteristic. Okay, yeah. Next CTG,
Sorry,
yes, Anjali.
Sorry, let's say the drop more than 60 is not concerning.
Drop more than 60 is not concerning. Delayed recovery is concerning. Okay.
They're concerning.
Drop more than 60 minutes is not concerning. Hello.
Yeah, but in the NICE
Hello?
guideline, if it drop more than 60, consider concerning feature.
It is concerning, Dr. Mrudula. It is concerning. For compression,
we'll go to the concerning.
No, drop more than 60. No, if it is lasting for more than 60 seconds.
Yeah.
And also
there is no drop. Drop has removed from this new definition, my dear. See, this is the concerning characteristics. There is no relation to the drop. Okay. Okay. Only thing, delayed recovery becomes concerning one. Okay.
Yes.
Yes. Yeah. Anjali, next CTG.
Doctor.
This one.
Yes, doctor. This CTG, we see around 3 to 4 contractions per minute. So we can see that the patient is contracting well. And as far as the baseline variability is concerned, it is less. It may be around 2 to 3 beats per minute. So it's basically less than 5 beats per minute. There are no decelerations, but there is 120. Yeah, there are no decelerations. So we have to continue the CTG as of now, just to see that it is not due to fetal sleep patterns or any other decreased variability is not due to any drugs, opioids, or fetal sleep.
Okay. Yeah. Yes. So this is actually we can say this as only thing there is variability is decreased. Only one non-reassuring feature is there, but still other things are good. Okay. So here only thing, loss of variability, we have to at least continue for 90 minutes. to do it to tell it as anything abnormal. Okay, and we have to we have to continue for at least 30 minutes to describe it as non-reassuring. So here it is not still 30 minutes. Okay, so we have to continue for 30 minutes to tell it is as suspicious CTG, because then loss of variability becomes a non-reassuring feature. Okay, so this CTG till now it is reassuring, but if it is more than 30 minutes, it becomes suspicious, and more than 90 minutes, it becomes abnormal or pathological. Okay, because this variability becomes abnormal. Okay. Yes.
Dr.
Next
Mrudula,
one.
can I please interrupt? Can I please interrupt?
Yes, Shraddha.
Here, Dr. Mrudula, I can see one acceleration, which is for 15 beats at least. And if correct me if I'm wrong. Yes,
this one. This early acceleration. Okay, this is one you are telling. But see, do you think it is more than 30 bits? See, it is 130. It is 140. So it has started. It is. I don't think it is more than 15 bits. It's hardly 10 bits. Okay, so we can't call it as proper acceleration here.
But still, my confusion is that. Please let me clear my confusion. If we see even a single acceleration, even if the other things are like variability is reduced, we term it as a normal CTG. Am I correct?
See, yeah, it
is
normal.
For this.
Till now also
not for this. In general, I'm saying.
Yeah, single acceleration. Single acceleration with other things. If there are no decelerations, we can definitely term it as normal. Okay, if we reduce variability.
Even if the variability is reduced.
Yeah, even if with variability reduced, if the acceleration is there, you can term it as normal. Okay.
Yes. Thank you, Doctor. Thank you.
And who has doubt? Yes. Who was asking me another one?
Hello, ma'am. Hello, ma'am. Ma'am, in this CTG, if we see the lines that 120, 30, 40, and 50 means one block is 10 beats, and the baseline is 130. Baseline is 130.
Yes.
And if we see the acceleration, it is 20 beats, isn't it, ma'am? This first one. Yes, this is one block is 10 beats. The first one, ma'am.
One block is 10 bits. Yeah. Yes.
10 beats.
Yes.
So
one
it
block is 10 bits, but here.
Not here, ma'am.
So you
the
can
first
see
one.
here.
The first one. Yeah, this one.
I'm telling for baseline heart rate. I think it is not 130.
Ma'am, variability is more than 5 also, ma'am. If we see in 1 minute segment, then variability is also 10 beats. If we can see, if you take a random 1 minute section.
5 to 10.
Ma'am,
what I'm telling here, baseline
heart. Yes, ma'am.
Baseline heart rate is around 135 here. Okay.
Yes,
here baseline heart rate, and again baseline has decreased. Okay, afterwards. And the next thing is the baseline variability in the first segment. It is okay. Okay, variability in the first segment is okay, and afterward it has dropped a lot.
It is
in the next segment. Yes. In the last 5 to 10 minutes, it has lost almost. It is less than around 2 to 3 bits only afterwards.
But there is no decelerations, ma'am. There is no deceleration. Baseline is normal, and also again at this whole CTG will be. Means on this means a small segment, ma'am. This is small segment only. The last means 10 minutes. If we see, we are saying that this is non-reassuring. No, rest other. If you see variability, variability is more than 5 beats. That is normal.
Yeah, that's what I'm telling. For that, we have to continue it for at least 30 minutes to label it as non-reassuring. That's what I'm telling you. So till now, we can't comment it as non-reassuring. Till now, it becomes normal only. Okay.
Yeah.
Till now, this CTG is normal. Till now, this all features are reassuring only, because still it is not crossed 30 minutes. Okay.
Okay.
Yeah. Next is Dikshit Gowda. You are Purnima, correct?
Mrudula, Mrudula, previous. Sorry to interrupt. Mrudula, previous CTG. Overall, overall baseline variability is less than 5 bits. Right? It's a non-reassuring feature. One non-reassuring feature.
Yes.
At any point of time, if we take a baseline, that is the baseline variability. That is less than 5 minutes. So one non-reassuring
baseline
feature.
to call. Wait. I'm telling. Baseline to become non-reassuring, we have to continue for at least 30 minutes. Okay? To become non-reassuring, we have to continue this CTG for at least 30 minutes. So after that only we can label it as non-reassuring feature. Till that we can't label it as non-reassuring feature. Okay? See, in the first segment, it is good variability. It's around 5 to 10. Again, it has started decreasing. So we have to continue the CTG and see what is the baseline. Okay? It is showing decreasing trend actually. First it was normal and then the baseline variability started to decrease. So we have to continue. But now we have to classify it as normal CTG only. Okay? This is normal right now. Okay? Yeah.
Ma'am, excuse me, ma'am. The previous one. Ma'am, the previous slide. Ma'am, this one block represents 10 seconds or 10 minutes. No, the other one, the next one you were showing earlier. Yes. So in this
one is 1 minute. This 1 minute.
Is 1 minute.
Okay. And this is 10 bits. Small block is 10 bits per minute. 10 bits. Got it? Clear? Vijayalakshmi?
Yes, ma'am.
Okay. Yes. Next is Dikshit Gowda. I think Purnima, no? Dikshit Gowda. Hello.
Yeah, ma'am. Yeah. It's Purnima.
Yeah. Go on. Yes. Go on next. This CTG.
Okay. Yeah. So she is having one contraction in 10 minutes, and baseline rate is around 160, and there are no activations, and variability is for less than 5 bits per minute, and there is a deceleration. Yeah, so this is a late deceleration, and so it it is 110. Yeah, it's a pathological CTG. So there is no actual, 60.
Hello.
Hello, ma'am. Can you hear me?
Hello. Can you hear me?
Hello?
I'm not able to hear you. Purnima. Yes. Go on. Yeah. Yes. Go on. Hello,
Baseline
Purnima,
rate is.
can you hear me?
Yeah, I can hear you, ma'am. Yeah, I can hear you very well.
Go on.
Yeah, baseline heart rate is around 160. Yeah, 160. And there are poor variability, like less than 5 bits per minute. So one is non-reassuring, and there are no accelerations, and there is deceleration. So one more non-reassuring. So it takes, it has a shallow deceleration, but it takes longer time to come back to the baseline. So, according to the Dr. C. Bravado, it's pathological.
Okay, yes, it is a pathological one. See here, but the baseline is more than 160. Okay, it is around 165 to 170 baseline is there. Okay, this becomes a non-reassuring feature. Contractions there are, see, this is one block is of around 3 minutes. Okay, so this is 1, 2, 3. So it is this to this, it causes 10 minutes. Okay. 1, 2, 3 and this one. So it is 10 minutes. So there are around 2 contractions. Baseline heart rate is around 165 to 170. There are no acceleration. Variability is definitely less than 5. Okay. But still there sometimes variability is preserved here. Okay. But there are late decelerations. Late decelerations are there, and along with this, so these late decelerations, we can tell right now it is non-reassuring. We can't tell it is abnormal right now, because we have to see it should be more than 50% of contractions. Here now only we can see one proper late deceleration. This is a shallow deceleration is there, but we can't call it as proper late deceleration. So this is a late deceleration and reduced variability along with that fetal tachycardia. So this becomes this pathological CTG. Okay. So, but late decelerations have not become abnormal yet. Okay, this is still non-reassuring feature only. We can classify it as. Okay, got it?
Yeah. Hello, ma'am. Hello,
Yes.
ma'am.
Bushra, yeah.
Ma'am, as we can see, in every 10 minutes, there are 3 contractions, no, in 30 minutes. This is 30-minute CTG. This is 30-minute CTG.
1 minute.
One contract.
This is not 30 minutes, my dear. This is 3-minute segment. This is 3-minute segment. So this is 1, 2, 3, 4, 5, 6, 7. This is only 20-minute CTG. This is not 30 minutes.
20 minutes.
Okay.
Ma'am, how we say this is 20 minutes? Ma'am, please can you
see?
tell
This
me?
is 2 black crosses. You are saying 2 black.
This
blocks,
is
okay.
okay.
This
These
is of
black.
10 minutes. Okay. This is of 10
Okay,
minutes.
fine.
Huh?
Okay,
yeah,
fine. Okay.
So this is pathological, but we have to take a conservative measure. But this late deceleration has not become any abnormal feature yet. Okay. Yes. Next one. 1 minute. Who was there after?
So sorry, as it is less than, it is considered suspicious as is less than 30 minutes.
This is pathological. This is CTG is pathological because there are 2 non-reassuring features. One is tachycardia, another is late deceleration.
But it is less than 30 minutes to less than 30 minutes for.
So, see, CTG you have to classify suspicious and pathological. When 2 non-reassuring features are there, 2 non-reassuring features are there, it becomes pathological. Late deceleration.
But should fill the
late
criteria.
Deceleration, any late deceleration is non-reassuring. Any late deceleration is non-reassuring. It is not normal. It is not reassuring. So late deceleration is non-reassuring feature and tachycardia is non-reassuring feature. There are 2 non-reassuring features are there.
Yeah, but should fill the criteria that more than 30 minutes to be late deceleration and tachycardia. Sorry?
Tachycardia, you should not wait for 30 minutes. Okay, so the baseline variability
for late deceleration, it is still less than 30 minutes.
Late deceleration less than 30 minutes. Late deceleration for less than 30 minutes also non-reassuring feature. Late deceleration for more than 30 minutes become abnormal feature. Late deceleration less than 30 minutes is non-reassuring feature. Okay, so there are 2 non-reassuring features. Yes.
Late decelerations less than 30 minutes. It should be for over 50% of contractions.
Yeah.
To be
so
called
here,
as non-reassuring.
So we have over 50. We have 2 contractions over 50%.
Any late deceleration is not a normal feature. Okay, and here you can see only 3 contractions you are seeing, and you are seeing at least 2 decelerations are there. This is shallow one, but still you can call it as a deceleration, and this is again one deceleration. Can you see from 170, 175, it has become up to 150. Okay, and it is a prolonged deceleration. So there are only 3 contractions, and for 2 contractions you are seeing this late deceleration.
Okay.
Yes. So 2 non-reassuring becomes pathological. Okay. 1 abnormal becomes pathological. So it is non-reassuring. It is not yet abnormal, but still it is a pathological situation.
Hello, ma'am.
Dr. Mrudula.
Hello, ma'am.
Yeah.
Over 50% of contraction. How can I see? I can see tachograph is more than 50. How can I see in CTG? Late deceleration more than 50. Yes, in nice CTG, late deceleration in more than 50% contraction means where can I see in Toko more than 50%? Yes.
See, you have to count contractions. See, there are 3 contractions, 1, 2, and 3. And decelerations are, there are 2 decelerations. This is 1 and this is 1. So there are more 2 decelerations for 3 contractions.
Yes.
So it has become more than 50%.
Oh, I see. Thank you.
Got it?
Yes.
Okay. Yeah.
Dr. Mrudula, you can just tell how many minutes CTG this is? This from where to where we will calculate?
See, usually this is the 3 minutes block is there, 1. This one block is 3 minutes. You can see this 1 square is of half minute. Sorry, this is half minute. 1 square is of half minute. Got it? This small square, can you see horizontally? This is half minute. 30 seconds.
Okay.
So this become 1 minute. 1, 2, and 3. So every this one large becomes 3 minutes. 3, 3, 3. Okay. So 1, 2, 3, 4, 5, 6, and 7. So this is around 20 minutes CTG is there. Okay.
Okay.
Yeah. Next one actually who was there? 1 minute. There are so
May I
many
do it,
chart
ma'am?
messages. Yes. Megha, yeah, go on. Your chance was there, no? Yeah, go on.
Yeah.
Start.
So, okay. So there are 3 to 4 contractions in 10 minutes. Sorry, 4 contractions in 10 minutes. Then the baseline rate is around 140 beats per minute. Actually, I cannot see this mark.
140.
This 120. This is 160 beats per minute.
See, this is 150 and this is 180.
Okay.
This is 150 and this is 180.
So this is somewhere around 165 beats per minute baseline heart rate. Then the variability is very poor, less than 5 beats per minute. And there are no accelerations and no decelerations.
So this is
the two non-reassuring features. So it becomes a pathological CTG.
okay. There are two non-reassuring features. Only thing, it has to be continued for it to take variability as poor thing. It has to be continued for at least minimum 30 minutes. Okay. So this is non-reassuring feature. Tachycardia is there. Baseline, it is no, it is baseline. See here, this is 150 and this is 180. So baseline is around 165 somewhere, 160 to 165 beats per minute. Variability is less than 5. Okay. There are no accelerations, there are no decelerations. So there are two non-reassuring features. It becomes pathological. Only thing, we have to continue it for at least 30 minutes to become pathological. Okay.
Okay. Ma'am, one more question I want to ask. How do we call this contraction as adequate contraction? Like, okay, the number of contractions is okay, but up till what mark should the contraction rise and what duration should it be to call it as adequate on this CTG?
Okay, so for contractions adequate, it is 4 to 5 contractions, and the strength of the contraction, I think it should be around 75 beats. Okay, 75. It should go up to the tocoprobe at least up to the 75. Okay, to call it as adequate.
And what are these marks? Like on the left, there is a different marking on the tocoprobe 2550, and in the middle, there is 125 250.
Yeah, exactly. I don't know exactly what these two scales are there, but usually there will be up to 100 marking will be there for contractions, correct? For all routine CTGs.
Okay, and so in this graph, the contractions are around somewhere around peaking around 50 only. So shall I
50.
say that these
Yeah.
contractions are adequate, or shall I not comment on this?
So it depends upon the stage of the labor, which stage right now she is, okay, to say it is a adequate contractions. Okay, so depending upon the dilatation and all these levels. So as I told you, nowhere we are commenting on CTG, okay, for the management. We have to take all other contractions, all other factors into account, okay?
Okay.
Got it? Yeah.
Yeah. Thank you.
Yes. Yeah, next one who was there?
Hello, ma'am.
Yes.
Yeah, please, can you show the previous slide? I want to ask, I couldn't get the time frame because when I counted it the way you described it, you said each lower horizontal block is 1 minute. So that means this is 6 minutes and it's already...
Horizontal block is 30 seconds. Small horizontal block is 30 seconds.
30 seconds, okay. Not 1 minute.
Okay.
30 seconds.
Okay. Yeah. So now who is there? Purnima is there, Megha is there. Devi. Next one. Devi.
Yes, Doctor. Yes, Dr. Mrudula.
Are you there?
Yes, yes. Hello?
Yeah.
Yeah, contracts.
Yes, this CTG.
There are about 3 to 4 contractions in 10 minutes. And the baseline heart rate is around 160, 165 to 170. Hello? Am I audible?
Okay. Yes. Yeah.
Baseline
Yeah.
heart rate is
Go on.
160 to 170. And accelerations. And yeah, accelerations are there, I feel. And there are late decelerations, right? There are late decelerations.
No. See, these are variable decelerations, okay? So can you see the baseline? Yes, it is definitely around 160 to 165, okay? Then variability in the previous part, it was around 5 to 6 beats, but later it has decreased. It is less than 5 beats per minute. In the later part of CTG, it has become decreased variability. The third thing is, yeah, accelerations are not there. If you consider this as a baseline, then there is no accelerations, correct? There are no accelerations. The decelerations, they are not at all related to the contraction. Can you see it? They are present at any time in between the contractions also, okay? So these are the variable decelerations.
Okay. They're seen after the
See, where this is
contraction.
after the contraction. See, where is this deceleration after the contraction? Contraction has over long back. Okay, the deceleration has not even started with the contraction. Okay, here also, here you can say it can late, but again here this deceleration has not started with the contraction. Okay, so these you can't properly correlate with the contractions. So these are the variable decelerations. Here you can see this deceleration is just like early deceleration. Okay, so these are variable decelerations. And variable deceleration, but these are not like somewhere there is loss of shouldering, but you can't properly tell it is with concerning characteristics. These decelerations, okay? Only thing somewhere loss of shouldering is there. Here there is loss of shouldering. Again, here there is loss of shouldering, but this deceleration looks to be normal. So this you can't tell it is exactly it is concerning characteristics, but these are variable decelerations. So this is again a reassuring. You can't properly tell it is a non-reassuring feature, but yes, tachycardia is there. It is non-reassuring. Baseline variability is somewhat decreased. Okay, so this is pathological. If it is continued for 30 minutes, and here it is continued for 30 minutes, you can see 510 to 520. So no, this is again, it is not complete 30 minutes. It is around 25 something. So it is not yet complete. Yeah, it is not complete 30 minutes till now. It's around 25 minutes somewhere. Yeah. Okay.
So here the variable contractions are there. Okay.
Decelerations are variable. Concerning characteristics, we can't properly tell it is they are with concerning characteristics. Yes, somewhere there is loss of shouldering in some decelerations is there. Okay, but not with all decelerations. Okay. So we have to continue this CTG and say, see, okay, to call it as suspicious or pathological for that matter. Yeah.
Okay. Okay, sure.
Yes. Next one, Salma. Salma, are you there? Hello, Salma is not there. Anyone volunteer?
Can I do, ma'am?
I'm not able to read your name. Please, can you tell me your name? It's in. Okay, Intezar. Yeah, go on. Intezar. Okay, go on. Yes.
It seems to me, ma'am, like a sinusoidal pattern.
Yes.
No. But it's not.
Hello. Go on. I'm not able to hear you properly. Hello.
This is like a sinusoidal pattern, ma'am, or not?
No, this is not sinusoidal.
This is not sinusoidal. This is not sinusoidal. This is a properly normal CTG, my dear. This is properly normal CTG. This is accelerations are there, baseline variability is good, fetal heart rate is around, baseline heart rate is around 140 beats, 135 to 140. Okay, so this is proper this thing, normal CTG. Okay, contractions are, see here, 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. So in these two, there are 2 to 3 contractions are there. Okay. Yes, Salma, we can't hear you.
Thank you, ma'am.
Yeah. Okay. Okay. Salma, we can't hear you. No, Jayalakshmi, you have not done. No, yes, you can do next. Yeah. Yes. Go on. Vijayalakshmi. Hello.
Yes, ma'am.
Yeah.
Yes, ma'am.
Go on.
1, 2, 3. So there are. There are 7 contractions in 10 minutes, and the baseline is 140, 121, 150. Is it 150? I cannot see it. Can we enlarge the thing, ma'am?
This is 140. If I do enlarge it, no, it will become this thing, more this thing. Yeah.
So this is 150, na ma'am. That marking is 150, I think. So
this line is 140. This line is 140.
Okay. So the baseline rate is 140. The variability is okay, 5 to 25, 5 to 10, between 5 to 10. There are decelerations after every contraction. I think it is all late decelerations. नहीं यहाँ पे variable है, I think. It's a variable decelerations, ma'am, and they are lasting for more than 50% of the contractions. Almost every contraction they are lasting, and it is this is hyperstimulation and pathological CTG.
Yeah. See, there are 6 contractions. See, this line and this line, it is 10 minutes. 1, 2, 3, 4, 5, 6. There are 6 contraction in 10 minutes. These are almost adequate contractions. Okay. So this is hyperstimulation because this is associated with the decelerations. Okay. Fetal heart rate abnormality is there. Okay. Along with that. So this is the hyperstimulation is there. Baseline heart rate is, yes, around 140. Baseline variability was previously preserved, actually until late also, but it has started decreasing. But yes, baseline variability still you can say it is a good thing, good one. Contractions, decelerations here again, it is between variable and early deceleration, because these are not early also. This is variable decelerations. See, you can't properly correlate it with contractions. Okay. So these are variable deceleration, not exact proper image of contractions. So it is not early decelerations, but these are variable decelerations. So variable decelerations along with this hyperstimulation. So this is suspicious CTJ, where basically you have to stop the syntocinon or you have to give the orbitalin. Okay. So if the hyperstimulation is corrected, because all other factors are good. Okay. So this can improve with this this thing if the hyperstimulation is corrected, this CTJ. Okay.
Okay.
Yeah. This requires corrective measure.
So is it only one?
Salma, we are not able to hear you.
Okay,
yeah,
ma'am.
it is only one non-reassuring feature. That too for, thank you. So that too for one non-reassuring, it is not yet 30 minutes. Okay, to call it is non-reassuring.
Okay.
So again, we can't say it is a non-reassuring yet. Yeah.
Continue CTG and
it is
it is a
hyperstimulation. That
suspicious
means no, we have to correct it. Correct the hyperstimulation first of all. Okay.
Okay.
Yeah.
Thank you.
Next one, who wants to do? I think this is repeated. No, not repeated. Yeah. Who wants? Nandita. Yeah, go on. Nandita?
So this is three contractions, and this is there is a deceleration. Variability is 1, 2, 3, 4, 5, 6 variabilities. there is a deceleration, which is late deceleration after the contraction occurring, and the baseline is I cannot see the heart without. It should be somewhere here. It should be here. Here it is 145, 150, 150. So this is 150 baseline, and there is these late decelerations, and the contractions are, and the variabilities are variability is maintained 1 2 3 4 5 6 7 8 7 to 8 in this segment. There here
your
five.
last thing was not clear. Yeah, I was not able to hear you. Yeah. Hello. Yes, Nandita.
Hello. Can you hear me?
Yeah. Go on. Yes.
Variability, I think here it is on this segment on the left side. It is about 1 2 3 4 5 6 7 variability. Here it is 4 variabilities, and there is a deceleration which is occurring after the contractions. So this is late deceleration.
No voice.
So,
yeah.
Late deceleration. So this is this has got one.
I'm not able to hear you, Nandita.
Now you can hear me. All of you others can hear me. Yeah. So it the baseline is 150. The variability is it was 7 to 8 on one segment and 5 on other. So variability is normal. She has 3 contractions, and there is a late deceleration because the deceleration is occurring after the contractions. So this is suspicious. Hello?
Suspicious. Okay. Yes. So you are labeling it as suspicious, correct?
Yeah.
Hello? Yeah. Yes.
Yes.
So see, yeah. So here it is 3 contractions per 10 minutes. Okay. Baseline variability, baseline heart rate is around 140 to 145 beats per minute. Accelerations are not there. Baseline variability is almost preserved. It is around 5 to 10 beats per minute. Okay. Yeah. Decelerations are there. They are late decelerations. See, you can see it is starting with the contraction. So these are the late decelerations.
Yeah.
And they are up more than 50% of contractions.
Yeah.
They are for more than 50% of contractions. So this is a non-reassuring, single non-reassuring feature. So right now it is suspicious. If it is more than, it lasts for more than 30 minutes, it becomes pathological.
Yes.
It becomes pathological. Okay.
Yes.
Yeah. Very good. Yes.
Thank you.
Yeah. Now next, who wanted to do 1 minute? Nidhi. Yes.
Yes, doctor.
Yeah, Nidhi. Yes. Go on, Nidhi.
Hello, doctor. In the previous CTG, sorry for interruption. In the previous CTG, it is for 30 minutes, right? CTG is more than 30 minutes. Then it will be one abnormal feature, and the CTG will be.
It is again not 30 minutes. How you can say it is 30 minutes? See, this one is 1 minute. So it is again 1, 2, 3, 4, 5, 6, 7. It is still yet 21 minutes only. It is not 30 minutes yet. Okay, it is not yet 30 minutes. This one big square is 1 minute. Okay, so this is 21 squares. This is 21 minutes right now.
But
it is not crossed yet 30 minutes.
Mrudula, but it is more than 50% of contraction.
Yeah, for last 6, but less than 30 minutes, no yet.
Yes, could you please explain what is more than 50% of contraction or late deceleration?
Yes. See here, how many contractions are there? 1, 2, 3, 4, 5, 6, 7 contractions are there. Decelerations are 1, 2, 3, 4, and this we can take as 5th deceleration also. Okay. So there are at least 4 decelerations are there with 7 contractions. That means it is more than 50% of contractions. Okay.
Yeah, if more than 50% and less than 30 minutes is considered pathological, yeah?
More than 50% in less than 30 minutes. If it becomes more than 30 minutes, it becomes abnormal feature.
No, if more than 50% of the contraction and less than 30 minutes is considered pathological.
Yeah, yes, Mrudula. More than 50%, less than 30 minutes. She's right.
It is non-reassuring. See again.
No, it is non-reassuring.
No, it's not. It is
non-reassuring.
Suspicious CTG.
No.
The overall suspicious.
I think we are talking about late decelerations, na. So it will be
deceleration non-suspicious, less than 30 minutes.
It is less than
It
30
will
minutes.
be.
It's non-reassuring. More than 30
Yeah.
minutes, it becomes pathology,
Yeah.
abnormal. Clear? Yeah. Yes. Nidhi? Yeah, go on.
Yes, in this CTG, the contractions are not adequate. The baseline risk remains the same. The baseline is about 160. Variability is okay, and there are variable decelerations, and there is only one reassuring feature, non-reassuring feature. So it is a suspicious CTG.
Okay. Now you can say these are the biphasic decelerations. Okay, with not with all decelerations, but 1, 2, and 3. These are biphasic decelerations, but otherwise these are typical variable decelerations. Okay.
Yeah.
Otherwise the things is 160 heart rate. Actually, it has crossed 160 also. Okay, so baseline is actually just more than 160 beats. Okay, but you can tell it is 160 also. So yeah, 160 also you can tell. So 160 is normal. Again, reassuring. Variability is normal. Okay. Accelerations are absent. Decelerations are variable decelerations, and they are not only thing. Some biphasics are there, but they are not with concerning characteristics. Other decelerations are showing typical variable decelerations. So till we can call this CTG as normal one. Okay. Somewhere it is concerning, not with all deceleration. It is a concerning feature. Okay.
Hello, Mrudula. How many concerning features should be there to call it as atypical variable decelerations?
It is not
Here,
how
there is
many.
only.
It is not
Yeah,
how
here
many,
it is.
but it should be present with all decelerations, no?
No, but
It is not
here
how
there is
many.
only one. Yeah, but there is one concerning feature, that is biphasic. So still we can call it as typical, right?
Typical,
As
not atypical. It is not with any concerning characteristic. That's what I'm telling. It is not with any concerning characteristics. Only 1 or 2 decelerations are looking biphasic, but all other decelerations are looking normal, typical variable decelerations. They are not with any concerning characteristics. Okay?
Oh, okay, thank you.
Yeah.
So this is not. This is what?
This is normal. Right now it is normal. This is normal CTG. If it is becomes for more than 90 minutes or this concerning this. Hello, who is talking? Hello.
Yes, ma'am. Yes, ma'am. Is that is to say all the concerning characteristics should be in all the variable deceleration in order to say that it is suspicious.
Yeah. If with all deceleration, if the concerning characteristics are there, then we can call it as a this thing suspicious. Okay, and that too it should last for at least 30 minutes. Okay, to call it as suspicious.
More than 50% of contraction now we have.
More than 50% of contraction, more than 30% becomes abnormal.
Yeah, so and this CTG is more than 50% of contraction.
Contractions are not adequate.
Here, first is contractions are not adequate. Second is the concerning characteristics are not present with all decelerations. Okay, only 2 decelerations we can see biphasic. All other decelerations are normal only, normal variable decelerations. Okay.
So,
but Dr. Mrudula, if we say that fetal heart baseline is on the higher side.
It is somewhat on higher side, but for that also we have to continue this for at least 30 minutes. Okay, to categorize it as suspicious. Right now, to categorize as suspicious, you have to see for other next decelerations how they are becoming. Okay.
Yeah.
Here in the last part, you can see the variability is also started decreasing.
Yeah.
Sorry, because there's no contraction, you not consider more than 50% of contraction?
See, there are no adequate contractions, so you can't comment on that, whether it is more than 50% of contraction or not. Okay, then there are no adequate contractions.
Okay.
So what is
What is the diagnosis of that CTG?
Right now, this is normal. Right now, normal CTG, we have to wait for
two deceleration with no concerning characteristic, no acceleration. Is it called normal?
Yes, variable deceleration up to 90 minutes are called normal only. Variable decelerations up to 90 minutes is normal. Okay. Yes, next one, who wants to do?
This is the sinusoidal pattern, ma'am, isn't it?
Yes. Yeah, go on, Intisar.
I'm sorry, I want to compensate for the last one.
No. Yes, next one you want to do? Yes. Anyone?
Can I do?
I said it, ma'am. It is the sinusoidal pattern here.
Yes, this is pseudo-sinusoidal.
Yeah, these are pseudo-sinusoidal. Yes, Intisar, I'm not able to distinguish you. I'm not able to.
I'm sorry, ma'am, because my name is written in Arabic. I'm sorry that I don't know how to change it in English.
But what you are telling, I'm not able to get you. What exactly you want to tell?
No, ma'am, I said this is the sinusoidal pattern because I want to compensate for the default before I have done.
Yeah. Previously you told sinusoidal. No, yes, this is definitely sinusoidal. Here, this is, you can see it is around between 20 or 20 bits. Oscillations are up to 20 bits. Okay. So you exactly, if it is crossing 20 bits, it will become proper sinusoidal. If it is between 5 to 10 bits, it becomes pseudo-sinusoidal. Okay. So here it has started lasting for more than 20 bits. Okay. So it can become pseudo-sinusoidal. Okay.
Dr. Mrudula, again no voice.
Can you explain Mrudula again?
Hello, no voice.
Yes, please explain this one. This is pseudo-sinusoidal. So please explain again, and we cannot hear you. Doctor, no voice.
We cannot hear you, Mrudula.
Just 1 minute.
Yeah, now it is fine. Now we can hear you.
Hello, am I audible now? Is it voice clear?
Yes, ma'am. Yes, we are very sorry. We are troubling you so much. Sorry.
Actually, no. Actually, the problem is with my connection. Since last 2 to 3 days, this is occurring to me. I don't know why.
Sorry. And it's so difficult to take class like this, and it's such a difficult, and everybody's bumping.
Hello again. Yes. Okay. See here. Can you see in 1 minute there are only 2 oscillations? Okay. Only 1 to 2 oscillations are there, and in the later stage they are lasting up to more than 20 minutes. Okay. So this is proper sinusoidal pattern. When there is less than 20 bits, okay, 5 to 10 bits, and frequency is more, like 3 to 5 oscillations in 1 minute, it becomes pseudo-sinusoidal. Here, see, can you see it is not proper pseudo-sinusoidal, but it has become sinusoidal later. Am I clear?
Isn't it waves are little straight rather than closer?
Am I clear?
Hello?
Actually, your voice is breaking. My voice is clear? Yes, yeah. Yeah, go on, Nandita. Yeah.
We're not hearing you. Please repeat.
Hello.
Yes, could you please repeat?
Wait.
Yes, ma'am, please repeat.
Your voice is very breaking. Hello?
Ma'am, sound is not okay. It's breaking.
No, but
Yes, doctor, your sound, I cannot hear you also.
yeah. Hello? Is it clear? My voice is clear, not breaking. Can you hear me?
Doctor, it is breaking in
Yes,
between.
ma'am.
Hello?
It's better now.
Hello, can you hear me now?
Yeah, we can
Hello.
hear you, Mrudula. Yes, we can hear you.
Yes, ma'am. Am I audible?
Yes.
Hello?
Yes, doctor.
Clear or it is still muffling?
Doctor, clear.
Hello?
We can hear.
Yeah, yeah, okay. See, only thing I wanted to tell you, sinusoidal and pseudosinusoidal, you have to see frequency in 1 minute. So it
Sound is breaking again, ma'am.
if it is 1 to 2 oscillations and the amplitude is yes. Hello. Hello.
Yes, doctor, we can hear you.
Yeah, okay. So see, if the frequency is only 1 to 2 oscillations and amplitude is more than 20, amplitude means change in the beats, okay? Amplitude means change in the beats. If the amplitude is more than 20 and the number of oscillation is 1 to 2, it becomes sinusoidal pattern. And if the frequency of oscillation, that means if there are 4 to 5 oscillations in 1 minute and the frequency is 5 to 10, amplitude of the, that means beat to beat variation. So change in the beats is 5 to 10 beats. It becomes pseudo-sinusoidal pattern. Am I clear? Am I clear?
Yes, yes.
Yeah. Okay. Okay. So this is about the CTGs.
Sorry,
Actually, I wanted. Yes.
sorry. So what is the difference from normal? It is the same also 5 to 25 oscillation of the variability.
See, there is no variability. It is a straight line. There is no variability. Only thing, these are oscillations. Okay. This is oscillation. There is no variability. Okay. There is no variability in this.
But it is the 20 minute CTG. It is the beep. The one is 1 minute.
See, this square is 1 minute. This square is 1 minute. This horizontal square is 1 minute. And here there is no need to classify. Any sinusoidal pattern is abnormal and this CTG becomes pathological. Okay. Any sinusoidal pattern is abnormal. Okay. Remember
Difference
well.
between pseudo-sinusoidal and sinusoidal is the number per minute. If it is low number sinusoidal, if it is more.
Yeah. Low number and high oscillations. Okay. So beats are more. Okay. And the number per minute are more. It becomes pseudo-sinusoidal. Okay.
Okay. Okay. Yeah, clear.
Okay. Actually, I wanted to do one more station, but I think the time is it's almost 11 o'clock here. So what we will do, we will just discuss the station. Okay. So not as a station, but we will discuss it as the CTGs only. Okay. So this station is according to the CTG interpretation and its management. Okay. So see the first patient. She's a 30 years at 35 weeks, admitted with spontaneous labor. She's fully dilated. Head is 0/5. Okay, that is not palpable. It is in left occipital anterior position, minimal capital, no molding. Good progress from 3 centimeter to full dilatation in 3 hours. She is pushing for 1 hour. Okay, so this is the CTG. Next thing. So who wants to interpret this CTG? First, you have to describe the CTG. Who wants to interpret it? Anybody? Yes, no Bushra. Anyone who has not done till now, who has not explained the CTG till now, anyone wants to volunteer, or I will give chance to Bushra again. Okay.
Can I
Yes, Bushra.
Hello? Can I do, doctor?
Bushra?
Hello? Hello, ma'am. Hello?
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 Hello.
Who is hello? Yes. I'm not able
Yes.
to hear you. Hello.
Yes. Can I interpret it?
Yes. Actually, I told you Busra. So next we will give. Next I will give it to you. Next CTG. Okay. Sama. Okay. Yeah. Busra, can you go on? Hello.
Hello. Hello. Are you asking me, ma'am? Your voice is actually breaking. I'm not sure. You're asking my name? Hello? Hello? Hello?
Yes.
Ma'am, I should interpret?
I'm not able to hear.
Yes, Bushra, she told you to do.
Okay. So, ma'am, can I see the first slide before this CTG? Can I see the first slide again, please? What I remember, this is 35 weeks with the fully dilated, pushing for 1 hour. And pushing for 1 hour means in the second stage of labor.
Not connected.
Bushra?
Hello? Yes,
No.
ma'am. Now I can hear you, ma'am.
Sorry. Yeah.
Hello?
Hello?
Yeah, ma'am, can I see the first slide? Can I see the first slide before the CTG? Hello? 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 Ma'am, can I see the first slide, please? Before this CTG.
Can we do some other time? Lot of interruption is there.
Yeah, ma'am. It's not means.
Yeah, we will do next time. Any other time.
Some other time we can request her. Yeah. Yeah.
And we are also studying.
Yeah.
Yeah. Bushra, go on.
Yeah.
Yes.
Go on. Okay, ma'am. Ma'am, just
Yeah.
I want the first slide, please, before I am again disconnected.
Okay.
Before this
1 minute.
slide, just
Yeah.
to see this factor. Okay, ma'am.
Yes. Okay.
She's
Yeah.
fully dilated. And ma'am, is it primary or second multi? Can I know?
Consider it as a
Primary or
primary.
multi?
This is a strategy, this
Okay.
thing, but consider it
Okay,
as a
ma'am.
primary.
On examination. Primary pushing for what I can interpret, primary pushing for 1 hour, fully dilated and left occipital anterior. And okay, so ma'am, in this CTG, the baseline is 140, 60, 70. This baseline is ma'am 170 to 175, 160 to 170 beats. And variability is okay, 5 to 10 beats, and it is having 1, 2, 3, 4, 5. Okay, ma'am, this is 20 minutes CTG, I think. 3 to 4 contraction per minute, and these are looking variable deceleration, and because they are variable decelerations with these are lasting for more than 60 seconds, so they are concerning variable decelerations.
Yes. Okay.
The overall, because this is heart rate is around 170 and variable deceleration, so for now this is with concerning characteristic, and 10-20 minutes I can see. So this is a suspicious CTG. We need to continue the CTG, and we need to means if she is pushing, we can expedite. Right now, this is a suspicious CTG, so we can means assess the patient and either continue. Huh?
Okay. Yes.
Hello.
1 minute.
It's
I
still
will tell you.
suspicious.
See, she is 35 weeks. Okay. She is in preterm labor, first of all. Okay. Remember, she is spontaneous, fully dilated, second stage, preterm labor. Okay, so that is the one factor. So this is the risk factor for her. The contractions are 4 contractions. These are seems to be adequate contractions. Baseline is around 165 to 170. So this is a non-reassuring feature. Okay, baseline heart rate is a non-reassuring. Variability is maintained almost. It is around 5, more than 5 beats. So variability is maintained. There are variable deceleration for more than 50% of contractions and with concerning characteristics. Okay.
Yes, ma'am. Yes, ma'am.
So,
but this is for 20 minutes only.
Yeah, right now it is for
This is
20
20.
minutes. But yeah, this is, but it is still it is reassuring, a non-reassuring feature because it is for more than, so it we have to wait for 30 minutes to it becomes this thing. And then 2 non-reassuring feature, that means it is almost pathological CTG. Okay, if it is just for more than 10 minutes, it will just for more 10 minutes it will become pathological CTG. Okay. So here we have to deliver her because all other factors are favorable for her instrumental delivery. Okay.
Yeah, ma'am.
Only
Can
thing we
deliver
have to
her.
assess her
Expedite
station.
her delivery.
We have to assess her station and we can do instrumental delivery. Okay.
Yes, ma'am.
So
Yes.
she requires delivery and we can do instrumental delivery for her. Okay. Yeah.
Yes.
Okay. Now the next thing. So with management band is deliver her mostly instrumental, assess for instrumental delivery, deliver her send cord paid cord blood gases. Okay. And yes, 35 right now it can be vacuum also according to new guidelines. You can apply vacuum. Okay.
Yes, ma'am. We can consider vacuum between 32 to 36 weeks.
36 weeks. Yeah. Okay.
Yeah.
But now we will be not be.
Yes.
Ma'am,
wait for.
we will not be. She is 35 weeks, so we will be not doing fetal blood sampling for her, no?
Yeah, right now
Or more
actually
than
she is
34.
fully dilated. She is fully dilated, pushing for one
We will
day.
deliver her. We will deliver. Right.
So there is no need for 35 weeks because she is in second stage. We have to deliver her. Okay, there is no need for blood sampling right now. So this next CTG, who wants to do Sama? Hello, Sama, are you there? Yeah, LR, whether in theater or in LR, depending on her station. Okay, if she requires mid cavity, you have to deliver her in theater. If she is low or outlet forceps, you can deliver her in the room. But other factors are very much favorable, so you can try it in room also. Yes. Next one. Anybody wants to go? Sama is not there. I think she's not responding. Anybody wants to go with next CTG?
Doctor, can I do?
I can do.
Yes. Anjali, Surabhi, go on.
Okay.
Yeah, so these are the
this is in IVF
first is the
pregnancy and 42-week pregnancy. Yeah.
Yeah, so these are the risk factors, and she's on oxytocin triple, so remember. Okay. Yeah.
For lack
So
of
this
power,
is
yes. So there are around 5 contractions in 10 minutes. And baseline, okay, I cannot see the marking.
See, this is 140 and this is 160. This one is 160.
This one,
this is
160.
160. And this is 140.
Okay, so the baseline is 160 beats per minute. And variability is around 5 to 10 beats per minute. And this is going, the deceleration is going till this marking.
This is up to, some decelerations are going up to 130. Some decelerations are going up to 130 also.
These are, I think, variable decelerations. And 1, 2, 3, 4, 6. I think due to oxytocin, the contractions are more, around 6 and 10 minutes. And these are variable decelerations.
Yes.
So
First,
otherwise,
your impression
I
of
don't
CTG.
really
Your impression will be how the CTG is first.
variability is fine. There are variable decelerations present, but no concerning characteristics I can see. So as for now, it is hyperstimulation with normal CTG.
See here, one thing is that baseline is around 160. Another thing I will tell you, see, because of the square are very large, very small, the variability is less than 5 only. Okay, it is between this 155 to 160 it is going on. Variability just around 5 or less than 5 you can tell here. Okay. Otherwise, yes, variable decelerations are there. There is no concerning characteristics, but they are for more than 50% of contractions. So this one, it is going in favor of fetal tachycardia. Okay. Baseline is just 160 right now. And again, variable deceleration are there and variability is somewhat less. So right now, this CTG, you can call it as suspicious, not pathological right now, but you can call it as suspicious, but it is due to hyperstimulation. Okay. So now your next management plan will be?
Stop symptom. To stop the oxytocin and do conservative measures.
Yeah.
To reposition the mother.
Yes. Reposition the mother. Stop the oxytocin. Take a senior review. Okay. Yes. Take a senior review will be your next management plan. So after this, yes. So unfortunately, the oxytocin was not stopped and labor was allowed to continue because the trace was erroneously interpreted as having acceleration. The woman is now 8 centimeter, head is 2/5 palpable, left occipital posterior, acute and molding plus. She has made 2 centimeter progress in last 8 hours. So this is the next CTG. Who wants to do?
And Abdullah, for first slide is considered suspicious or pathological because we have
suspicious.
We have two features: low variability and variable deceleration more than 50 of contraction.
They have not crossed 30 minutes yet.
Yeah, but it is more than 50% of contraction.
But not cross 30 minutes. Late decelerations and variable deceleration, there is difference. Late deceleration less than 30 minutes is non-reassuring. Variable deceleration becomes non-reassuring if they are more than 30 minutes. Okay.
Yeah, but there is two suspicious. Less than 30 minutes suspicious for variability. And
it is non-reassuring. It is non-reassuring. So, okay, but see,
if we have two features not reassuring, it would become pathological. So variability, one of them, and variable deceleration.
These are not atypical variable, atypical deceleration.
Sorry?
Why you want to call? These are not with concerning characteristics.
Yeah, but it considers suspicious as it is more than 50% of contraction.
With concerning characteristics. Variable deceleration with concerning characteristics will be termed as suspicious. This thing, okay? Variable deceleration, typical variable deceleration, you can't call it as a non-reassuring, abnormal feature, okay?
So there is one suspicious feature, only the variability. Oh, okay.
One non-reassuring feature becomes suspicious if it is more than 30 minutes. If it is more than 30 minutes, and if it becomes this thing concerning characteristics, it becomes pathological. Okay. Till now, it is suspicious. Okay.
Okay, yeah, clear. Thank you.
Then I wanted to ask one question that since this patient is having risk factor that she is in labor and she's on oxytocin and it's IVF pregnancy, it's 42 plus. So still we will not consider it as a variable deceleration of less than 30 minutes despite.
So these all risk factors are considered.
Yeah. Okay. So
these all risk factors are considered for late decelerations. Okay, the risk factors will be considered for, yeah, okay.
Okay.
Ma'am, I think for variable deceleration also they are considered, no? There is one variable deceleration also in abnormal,
Yeah, but they should
abnormal
be with
feature.
but they will be concerning, the deceleration should be concerning characteristics.
Ma'am, is that not looking like W biphasic pattern, loss of shouldering, decreased
Variable
variability?
deceleration.
Yeah, variable deceleration. Loss of variability is loss of shouldering is there, and W pattern. These variable
Again,
decelerations.
your voice has become the same.
Ma'am, I'm saying this variable decelerations are having biphasic pattern and also loss of shouldering also. So it looks like concerning features. And in a high risk situation, if less than 30 minutes also, they become significant. Become means abnormal feature.
Your voice is breaking. I'm not able to hear you at all. Hello?
Hello, can you hear me now,
ma'am? I'm not able
ma'am?
to hear you. Hello, can you hear me?
Yes, ma'am, I can hear you. Can you hear
Right
me?
now, yes, I can hear you. Yeah.
Okay, ma'am,
Yeah. Go on.
I'm
So
saying that
So you were telling there is loss of shouldering.
Yeah, loss of shouldering as well as biphasic. These variable decelerations are looking biphasic, most of them. W pattern, this biphasic they are looking. And ma'am,
1, 2, 3, 4. Yeah.
They are looking biphasic and also loss of shouldering is there. So these variable decelerations are with concerning characteristics, and in a high risk situation like a post-dated IVF, so and variability is also around 5 or less than 5 only. So these two means this will make this variable deceleration as abnormal feature, isn't it? Variable deceleration with concerning characteristics in a high risk situation.
This will become non-reassuring.
Abnormal. Abnormal feature.
High risk becomes abnormal.
High risk
variable deceleration with concerning characteristics for more than 50% of contraction, more than 30 minutes. With risk factors becomes abnormal. Less than 30 minutes, it is a non-reassuring feature.
Okay, ma'am. Okay.
So here you can tell there are two non-reassuring features. If you consider this variability is less than 5, there you can say there are two non-reassuring features. This CTG can become pathological. Okay. So yes, this CTG, yes, you can say it is a pathological CTG. But yes, then the next management will be the same. Whether it is a pathological or whether it is a suspicious, first you have to stop the oxytocin and you have to watch for the further CTG. Correct? Got it? First, you will be stopping the oxytocin. You are not going to deliver her immediately. You are going to stop the oxytocin first because this can be because of hyperstimulation. Correct? Am I audible?
Hello, ma.
Hello?
Is this suspicious or pathological?
Yes.
Is this suspicious or pathological?
This is pathological. Right now, you can tell this is pathological. There are two non-reassuring features. Yeah. So the management will remain the same. You have to change her position. You have to stop her oxytocin. Take her. What is? The baseline here is around 160. 160 beats per minute is the baseline.
Which is normal.
So finally,
the baseline is normal. The baseline variability too is normal because it's like 5 to 10 minutes.
Variability is less than 5. Here variability is less than 5. Most of the time the variability is less than 5. It is between 155 to 160 only.
Hello, ma'am.
Yes.
Hello, ma'am.
Yes.
Ma'am, this variable deceleration, if more than 50 concerning variable deceleration, if more than 50% of the contractions, if for 30 minutes or less, 30 minutes or less in a high risk situation, as this is a high risk woman, post-dated patient, and IVF pregnancy. So can we consider this as a high risk, or only we have to consider that meconium and blood and means rupture only high risk?
Yeah, there they have given only meconium and vaginal bleeding. In presence of bleeding and meconium, it is considered as high risk factors. Other factors should not be considered as high risk to labeling decelerations. Okay, for labeling decelerations.
Okay.
But in overall interpretation, while deciding the management, you have to take into consideration all risk factors. Okay. But still, it becomes non-reassuring feature is there. Definitely, there are two non-reassuring features. So it becomes a pathological CTG. If it is pathological, so the management right now will be the same. You have to stop the oxytocin and CTG. Yes. Anybody?
Yes, second one, no, I will take. So this patient, the oxytocin was not stopped. The CTG continued. She has molding. She has caput, and the CTG showing a hypertonous uterine contraction.
Anyone want to? Am
Hello?
I audible?
Hello? Hello? Hello?
Yes,
Hello?
Dr. Mrudula, you are not audible.
No, madam has been cut. I mean, see this internet.
Okay, because down it is coming as presenting. That's why I thought she is talking.
No.
Okay. Okay. But then in the last CTG also, less than 5 beats should be for 30 minutes now.
Yeah.
Variability
But here
also should be for
lot of uterine contraction. See that there are some shouldering. Means this is the tachysystole.
Yeah, that's true.
Systole, and it has got a late deceleration and variable deceleration, and there is no complete recovery also. So she needs urgent delivery.
Yeah.
And in the end, I think they have done cesarean section, and the baby's cord blood was 6.19 and 6.17, like that. That is what was given in strategy.
Okay.
Am I audible? Hello.
Yes, now you are audible.
Yeah. Okay. Yes. This CTG.
This CTG, it has shows hyperstimulation tachysystole, hypertonus contractions, and it's going late deceleration, and then there is no complete recovery of the late deceleration. So this needs urgent delivery. Hello.
Yes. So this is yeah. So this is first is the baseline. Again, there is hyperstimulation is there. There are more than 6 contractions in 10 minutes. Can you hear me?
Yeah.
My voice is clear?
Yes.
So there are around 6 contractions per 10 minutes. The baseline heart rate is around 170 here right now. First it was 170 and there is then decrease in the baseline around 140. So there is decrease in the baseline afterwards. Again, there are, you can see there are, actually again here you can't properly label it as late deceleration, but first there were variable deceleration and then it has gone to the prolonged decelerations. Actually, they have become prolonged decelerations afterward, more than 2 minutes. Okay, and there is with loss of the baseline or decreased baseline. Okay, so this has become concerning characteristics decelerations and with hyperstimulation. So this has become right now, this is pathological CTG, and this pathological CTG along with 8 centimeter dilatation and molding and with the risk requires urgent category 1 cesarean section.
Cesarean section, yes.
Yeah, okay.
Yes.
Yes. Okay. So now this is one. There are, I think, two CTGs are there. Okay. Yes. So this is a 40 years, 41 weeks. She is induced right now on oxytocin, fully dilated, palpable head. Capillary is there, molding is there. She is pushing for 1 hour. She is a previous section. Okay. So yes. This is
deceleration and scar rupture.
Acute bradycardia.
Yeah, acute prolonged deceleration and then acute bradycardia and loss of contractions. Fully dilated with loss of contractions with prolonged deceleration, scar rupture.
Scar rupture.
Okay. So, yeah. So she for cat 1 cesarean section. Okay. This one. So 20 years old, para 1, previous nausea and vomiting diarrhea induced at 33 weeks for FGR, okay, with prolonged rupture of membranes, chorioamnionitis. She is on oxytocin, temperature 38.5. She is on intravenous antibiotics. Okay, so yes, describe the CTG.
This is sinusoidal.
No, baseline is 160.
No,
baseline is 160.
Baseline is around 160 to 170
to 165. Yeah.
165. Yeah, 165.
3 to 4 contractions in 10 minutes.
Yeah.
With baseline variability around 5, going somewhere up till and no accelerations and no decelerations.
No decelerations. Okay.
Yes.
So actually variability is actually somewhat reduced. It is not, you can't tell it is exactly 5, it is less than 5. Okay. So this is 160 and this is 165. So it is not 5 also. So actually this is non-reassuring CTG. Right now this is non-reassuring. Okay. So
and even baseline is also non-reassuring.
Baseline also is non-reassuring. Okay.
Yeah. 2 non-reassuring. So it is pathological.
2 non-reassuring. But yes, still again for variability, you have to wait for at least 30 minutes, correct?
Yes.
So right now this is non-reassuring, suspicious CTG.
Suspicious.
Right now it becomes
suspicious.
So now she is basically tachycardia and pyrexic. So first what
she
we
is
have to do?
PPROM. We can start chorioamnitis with 38.5 degrees. IV antibiotics.
She's already on IV antibiotics. So you have to give her antipyretics and
antipyretics.
And hydration. Position, oxygen.
Rehydration, IV fluids.
Oxygen is not at all required. Okay, oxygen, please don't tell oxygen for any CTG. Unless she is hypoxic or this thing, there is no need of oxygen. Okay, so no need. No, you should not tell oxygen in any CTG.
Only for maternal indication oxygen. Yeah. Not for feet.
38 temperature, she is having chorioamnitis. That is why. No?
No. Unless her oxygen saturation falls, there is no oxygen. Okay. For maternal hypoxia only you have to give oxygen. Here only antipyretics and rehydration. Okay.
Yes.
Only rehydration and antipyretics. So you will start with that. Next, the labor continued after intravenous hydration and paracetamol. Now she is fully dilated. Head is 1/5. Deflex ROT, caput and molding. Okay. No accelerations was noted after scalp stimulation also. After 90 minutes, CTG was recorded. And this is the CTG. Go on.
Again, the baseline is 160. Yeah. Again, the contractions are around 2 to 3 in 10 minutes with a baseline of 160 beats per minute. And again, the beat to beat variability is around 5, less than 5, I can say. And there are decelerations going up till 140.
Yes.
And those are
Yes, go
and
on.
they are with respect to contractions, they are late decelerations.
Yes.
Yeah. So pathological CTG.
So this becomes pathological CTG, and you have to, with this capute and deflex ROT position and these things, you have to deliver her with cesarean section only. Okay.
Okay.
Yes. Now this is again one more clinical scenario. She is 35 years, primary, generalized abdominal pain, reduced fetal movements at 39 weeks, unwell, fever and chills, pyrexial, temperature 38, pulse is 120, blood pressure, again hypotension, tenderness, uterine tenderness is there, baby is cephalic, 4/5 palpable, vaginal is uneffects, closed cervix, blood count showed 29,000 WBC and hemoglobin of 7.9. Okay.
Sepsis.
And
She's in sepsis.
yes, she's in sepsis. And this is the CTG. I think this we have discussed such CTG previously, correct? So without any contractions, she is having decelerations. Okay.
Spontaneous
There is
decelerations.
no.
So this is the
And there is
hypoxic
fetus.
This is chronic hypoxia.
Yeah. So this is the hypoxic fetus, and again with this thing sepsis. So first we have to, in the management plan, first we have to treat her sepsis.
Sepsis 6
correct?
bundle.
Sepsis 6 bundle we have to carry out, and after maternal stabilization we have to deliver because actually
Here
So
the
first maternal
hypoxia is
stabilization.
because of Dr. Mrudula. Here the hypoxia is because of maternal hypotension. So first we need to resuscitate.
Yes,
so the
first
CTG
maternal
may
resuscitation.
CTG may improve also in that.
Yes, definitely. But we have to see for the cause of maternal sepsis. We have to see whether there is any problem with her. Okay, so if there is fetal, some infection is there, in that case we may have to deliver also. Correct. But only thing is, first is the maternal resuscitation, and sepsis 6 bundle will be the first management, and then depending upon the next CTG we have to see. Okay.
Yes.
Mrudula, regarding this or previous one for pathological CTG, there is no rule for fetal blood sample before delivery?
For this patient, see, she is already having ROT. See here, this thing, when you see, already
fully
the CTG has
dilated.
been,
Fully dilated.
she's
dilated.
fully dilated, ROT, capute and molding is there. So what is the now? There is no role of fetal blood sampling.
No role of yes.
She's
No role of
fully
fluid.
cephalopic disproportion. Okay.
Expedite delivery.
Yeah.
Okay. Yeah. Okay. So this was the last. So I don't know. I have given a lot of trouble to you.
Thank you so much, Mrudula. Thank you so much.
I have given a lot of trouble. I can understand because I was irritated.
Thank you so much.
Yeah. Okay then.
Thank
Okay.
you.
Bye.
Very nice question.
Yeah. Thank you. So I will post this thing recording also afterwards. Okay. Yeah. Bye. Bye.
Okay. Thank you. Bye.
Telegram link to the Telegram, please.
Telegram, it is MRCOG intense preparation. MRCOG part 3 intense preparation. I think the link is there. I have to. Can you see? See, you can visit this Facebook page or YouTube channel also. MRCOG preparation. Okay. MRCOG preparation part 2 and 3 is the YouTube channel. Okay. In some other way, I will post the link again. And right now, I can't post the link here.
Yes, send the link here.
Yeah, I will send you, or you can just send me a Telegram message. I will post you the link. Okay. Please send me a Telegram message. Telegram group is MRCOG part intense preparation part 3 general group. Okay. Or please all of you who wants Telegram group, send me the message, Telegram message. I will give you the link.